You. Hold on, and a pandemic winner. You're not wearing a mask, you're not washing your hand, and you're not keep the required 6 feet distancing from other people. And what could that really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here why you are going to do for all the way. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance please, and thanks.
Hello Jamaica, I'm Dion Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older like me and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated. and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vax in 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Booking your COVID-19 vaccination appointment is simple. Use one of 2 options. Option 1. Register using the online portal at the Ministry of Health and Wellness's website. Go to www.moh.gov.jm, click Apply Here for COVID-19 vaccinations, and follow the instructions on screen. Enter your mobile phone number. You will receive a text message with a one-time password. Enter it on the site to confirm your account. Fill in the information requested. Choose your parish and a vaccination center there. Then schedule a date and time convenient to you. You will receive a text confirmation with the details of your appointment. Option 2. You may also book your vaccination appointment via telephone. Call the National Vaccination Center at 888-1-LOVE. That's 888-663-5683. A representative will take your information, book you at the nearest vaccination site, and register your appointment. You now have a vaccination appointment. For your first dose, when going to the site, take your TRN and a government-issued identification or letter from a Justice of the Peace. For your second dose, take to the appointment your vaccination card, TRN, and a government-issued identification or letter from a Justice of the Peace. You may ask a relative or friend to help you book your vaccination appointment. Book your COVID-19 vaccination appointment today. Get vaccinated. Get back to life.
Some of we have all sorts of excuse as to why we don't want to wear the mask. The place too hot. We're not used to it. It's not comfortable. Look, you know. Wake up and smell the country chocolate. Them excuse, they're not going to make it. Yeah, me know the place hot. But you don't want to feel COVID-19 fire in your lungs. And used to. The only way to get used to a thing is with practice. So practice and wear your mask. And as for the start now about comfortable, not no more comfortable than being COVID-19 free. So find a mask we fit.
COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
From worry over your finances to mask wearing and physical distancing from your family and friends, your concerns about COVID-19 may be many, but you can overcome. Take care of your mental health. Keep a journal. Talk about how you're feeling with someone you trust. Exercise. And yes, take the time to smile.
Hello. Yeah, you. Hold on, and a pandemic winner. You're now wearing a mask, you're now washing your hand, and you now keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here why you are going to do for all away. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Dion Jacksmiller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, roasting with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older, like me, and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vaccine 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Booking your COVID-19 vaccination appointment is simple. Use one of two options. Option 1. Register using the online portal at the Ministry of Health and Wellness's website. Go to www.moh.gov.jm, click Apply Here for COVID-19 vaccinations, and follow the instructions on screen. Enter your mobile phone number. You will receive a text message with a one-time password. Enter it on the site to confirm your account. Fill in the information requested. Choose your parish and a vaccination center there. Then schedule a date and time convenient to you. You will receive a text confirmation with the details of your appointment. Option 2. You may also book your vaccination appointment via telephone. Call the National Vaccination Center at 888-1-LOVE. That's 888-663-5683. A representative will take your information, book you at the nearest vaccination site, and register your appointment. You now have a vaccination appointment. For your first dose, when going to the site, take your TRN and a government-issued identification or letter from a Justice of the Peace. For your second dose, take to the appointment your vaccination card, TRN, and a government-issued identification or letter from a Justice of the Peace. You may ask a relative or friend to help you book your vaccination appointment. Book your COVID-19 vaccination appointment today. Get vaccinated. Get back to life.
Some of we have all sorts of excuse as to why we don't want to wear the mask. The place too hot. We're not used to it. It's not comfortable. Look, you know. Wake up and smell the country chocolate. Them excuse, they're not going to make it. You may know the place hot. But you don't want to feel COVID-19 fire in your lungs. And used to. The only way to get used to a thing is with practice. So practice and wear your mask. And as for the start now about comfortable, not no more comfortable than being COVID-19 free. So find a mask with fit.
COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
From worry over your finances to mask wearing and physical distancing from your family and friends, your concerns about COVID-19 may be many, but you can overcome. Take care of your mental health. Keep a journal. Talk about how you're feeling with someone you trust. Exercise. And yes, take the time to smile.
Good morning. May I ask you to stand for the playing of the Jamaica National Anthem. Thank you. Mrs. Shirley Hibbert, Program Development Officer, Emergency Disaster Management and Special Services Branch of the Ministry of Health and Wellness, I will now bring the invocation. Mrs. Hibbert.
Thank you very much, Faye Ellington. Good morning, brothers and sisters all. May we remain in an attitude of worship. Let us pray. Our Father and our God, we're truly thankful to you that you have blessed us with heavenly blessings, that you have brought us here this morning to celebrate together. We thank you, Lord, for your keeping care over us. You have guided, you've guarded, and you have protected us. We thank you, Father and God, that we can come together for this, another annual research conference. We pray your special blessing over all. Thank you, Father, for all the presenters. Thank you, Lord, for all who made it possible for this function today and over the next 3 days. We pray for wisdom, knowledge, and understanding, that we, Lord, would pay attention to the things that we'll be hearing, and that at the end of it all, we'd each go away having learned something new or reinforced something which we will use for the betterment of this country. We thank you and pray for our leader, our Minister of Health, our Chief Medical Officer, our Permanent Secretary, all the directors, middle managers, line staff, all of us as together, Lord, we seek to make this ministry the best that it can be. We seek to be the best that we can be so that we can serve our country faithfully. We ask for your guidance and your blessing as we go through today. We give you thanks in your worthy, holy, and precious name. Amen.
Thank you so much, Mrs. Shirley Hibbert. Let me acknowledge the presence at this time of our Minister of Health and Wellness, Dr. Christopher Tufton. Thank you so much for being here, sir. Our Chief Medical Officer, who's been working so hard. I said to her when I saw her this morning, I hope you're getting some rest. And, she's just going to rise to the occasion. Dr. Jacqueline Bisesa McKenzie, all persons who are watching on various platforms, and the members of the team here from the Ministry of Health and Wellness, and also those persons who are supporting us via technology. Let me apologize for the late start and introduce myself. Good morning, I'm Faye Ellington. I'm fully vaccinated and giving thanks and awaiting my booster. I wonder if the minister here that I'm awaiting my booster. Okay, fine. Right, and I think it's important for us to say that in these circumstances, when there's so much hesitancy and fear-mongering, when social media has been wreaking havoc across the world with the conspiracy theories. So I just thought I'd say that. Before I bring you on, Dr. Jacqueline Biseso-McKenzie, could I just put the conference in context? The Ministry of Health and Wellness is staging the 12th renewal of the annual National Health Research Conference from November 17th through to the 19th, 2021. Given the current realities of the COVID-19 pandemic, the event will again and is being staged virtually. We thank you from wherever you are that you have connected. The conference theme this year is COVID-19 Year in Review, a multi-dimensional perspective. Now, this is indeed pertinent given the impact of the pandemic on the individual, the community, and at national levels. The conference will feature high-quality abstracts on 1, COVID-19, 2, non-communicable diseases, NCDs, 3, health economics, 4, gender-based violence, and 5, public health advances. The conference will likewise feature high-quality research from other areas. The conference is indeed, just to remind you, in its 12th year. The themes since the inception will be shared with you during the course of the 3 days, but I'd like to add that last year the theme was the COVID-19 experience adjusting to the new normal, and the new normal will be like this for a very, very long time. Now it gives me great pleasure to bring to the microphone at this time the Chief Medical Officer from 2018, and then after 2018, a pandemic fell into her lap. And I think all of us in Jamaica will agree that she's been outstanding in her handling of this. So could you help me welcome at this time Dr. Jacqueline Biseso-McKenzie.
Master of Ceremonies, Ms. Faye Ellington, Dr. the Honorable Christopher Tufton, Minister of Health and Wellness, Mr. Ian Stein, PAHO WHO Representative for Jamaica, Bermuda, and the Cayman Islands, Dr. Varouche Dade, Director, Caribbean Regional Office, Centers for Disease Control and Prevention, Dr. Joy St. John, Executive Director, Caribbean Public Health Agency, Directors of the Ministry of Health and Wellness, members of the National Health Research Conference Planning Secretariat, distinguished guests, members of the media, ladies and gentlemen, good morning. It gives me great pleasure to welcome you to the 12th Annual National Health Research Conference, one of the most anticipated events on the calendar of the Ministry of Health and Wellness. Our convening here and in the virtual space highlights the priority placed on health information. Health research plays a vital role in advancing societies through significant discoveries and new findings that support improvements in healthcare. As we approach December 2021, we are reminded that December 2019 was when the novel coronavirus was detected in Wuhan, China. The world will recognize that for 2 years, every country has been struggling to navigate unknown waters. Jamaica has been no different. We have had to be analytical in our approach and bold in our interventions. It has been a daunting journey, but at the same time, new and exciting. Innovations in surveillance, monitoring, coordination, containment, clinical management, communication. Innovations that change what normal looks like and enable quicker and more effective responses in the future. Shall we forget? Shall we start over in the face of any new emergencies? Shall we suffer the pitfalls of the learning process again? No, we shall not. We should not, and we will not. And this is why we are here. This National Research Conference this year focuses on COVID-19. The National Research Agenda provides the opportunities and highlights the importance of documentation and research. I look forward to seeing what COVID lessons learned has been immortalized and preserved for generations so far, and hope that this buffet of works will be a stimulation to others to start writing. I congratulate the organizers, Dr. Webster Carr and Dr. Grant, and their teams on their diligence and steadfastness in organizing and implementing this conference each year. And I'm sure that this conference will be a success. I wish you 3 days of engorgement on the data that is going to be presented. Thank you.
Thank you so much, Dr. Jacqueline Bisesa McKenzie, and thanks to the young lady who is making sure that the lectern is sanitized. No, sometimes you take these things for granted and don't remember to do that because these are different times. And somebody has to do it. So I'll get your name in a while because I'd like to speak the name. It's important. And so we move on. But before we do, remember what Jacqueline Bisesa McKenzie just entreated us to do. Shall we forget? Shall we forget? And she spoke of the buffet of work which will be unleashed on the fraternity, and hopefully that media will be able to connect with some of it to ensure that a wider complement of persons are able to use it. And speaking of the wider complement, we're going to be joining a member of the opening ceremony on Zoom, and this Dr. Joy St. John, Executive Director of the Caribbean Public Health Agency, CARPHA. It's important because in the Caribbean we had to collaborate. We always have to collaborate on so many issues, and this one was one such. So could we welcome on Zoom Dr. Joy St. John.
Thank you very much, Madam Moderator. All protocols being observed, I am happy that yet again we can meet, albeit virtually, to open the Jamaica National Health Research Conference. Last year, we had the hope of finding vaccines and treatments which would rid us of having to deal with COVID-19, but alas, that time has not yet come. Now in the 12th year of the Jamaica Health Research Conference, I applaud the organizers for persevering to ensure that the public health research findings are widely disseminated through this medium and that products can be generated that can inform decision-making at both the national and regional levels. I really like your theme and the treatment of it through your packed agenda. Certainly, for just under 2 years, we have been consumed by activities surrounding COVID-19, with adjustments to the way we have grown accustomed to living, playing, and working. Your agenda sessions reflect how COVID-19 has permeated through everything and affected everyone. But through all of this, I keep asking myself, why is this virus still with us? Why is it still so destructive to life and livelihoods? Why is it that although we see what is needed to overcome its effects and minimize its harm to our family, friends, communities, and countries, we still cannot seem to reach the elusive end of this dark and long pandemic tunnel. Jamaica has experienced every effect of COVID-19 with several waves and the recent spikes due to the highly transmissible Delta variant. Jamaica has also received vaccines, which were not available 1 year ago. Could it be that as a collective, humankind has not learned the lessons about the need for change that this virus is trying so hard to teach us? My hypothesis is that COVID-19 is trying to teach us that we cannot go back to the old structures and strategies and ways of living, because every time we do, the virus changes and unleashes a new variant, which is more difficult to overcome. What have our experiences in the Caribbean revealed and hopefully taught us? The early decisions of the CARICOM heads of government were manifested by uncommonly low cases and deaths due to a health-preserving policy intervention to bring about an all-of-society approach to the COVID-19 response. Never before have I witnessed the collaboration of all sectors in society, in many countries, all at the same time. So many were so willing to collaborate to fight for one common goal, fighting this pandemic. This is the best example of the multidimensional perspective, which is the theme for this year's conference. This is also one of the most intensive experiments in operationalizing the determinants of health approach on a societal level. The ordinary Caribbean man, woman, and child understood COVID and what to do about it in a way that I've never seen before. And now more know and understand about public health and good hygiene than ever before in my lifetime. Unfortunately, our economies, which are very dependent on tourism, took the brunt of the COVID-19 curse and nearly died. So the pendulum is swinging to a heavier focus on economic activity. And CARF is working very hard to make the tourism sector more fit for the COVID purpose, even as the region embraces some of the old ways of doing tourism activity. Every sector would have adjusted to respond to the needs of their sustainable operation. I am hoping with more adjustments, there are public health best practices hidden in all these new operations. Next year, I hope research will show what interventions were the most effective from the health and the economic perspectives. I cannot conclude these remarks, however, without mention of another tremendous evolution over the past months. The advent of disinformation and its negative impact on vaccination uptake has snowballed into many, too much preventable illness and death. I really hope that your conference will share insights of how to address this. COVID-19 will not be our last health challenge, and we need to be prepared and well-resourced to detect and stop the disinformation infodemic and deal with the behavioral change challenges next time. I encourage all of you public health professionals and researchers in your future research. Do not limit your scope to what is before you. Dig deep, explore for hidden innovations and best practices that exist right here in the Caribbean region. Let us make the Caribbean the model to follow. I use this opportunity to wish you success in this conference as we highlight the research that will shape the future policy direction in the region. I thank you, Madam Moderator.
We thank you, Dr. Joy St. John, for the comments you shared with us. You ask I wonder if we paid attention to the lessons that we learned from COVID-19. And you raise things like hygiene. I'd just like to say that we are at the place where we need to return to good hygiene practices, whether or not there is a COVID-19, whether or not there is a pandemic, because some of us became a little slack where that was concerned. One of the lessons we learned, and it wasn't just because of COVID-19, but it was heightened because of COVID-19, was that we should be inclusive. And that the persons with disabilities needed to know what we were saying. They needed to get the messages that we were transmitting. And you will notice that this morning we have someone signing for the deaf community, and that's Antoinette Akon. She's been working tirelessly, ensuring that this event and so many others to do with COVID-19 and outside of COVID-19 is communicated to those persons with disabilities who need this kind of assistance. So I want to thank Antoinette Akon for that. I continue now with yet another Zoom presentation. Dr. Farouk Dede, Director, Caribbean Regional Office, Centers for Disease Control and Prevention. We welcome you to the conference, Dr. Dede, and look forward to your comments. Good morning.
Good morning, Master of Ceremony. Thank you, and I hope you and the audience can hear me clearly. Honorable Minister of Health and Wellness, Dr. Christopher Tufton, Chief Medical Officer, Minister of Health and Wellness, Dr. Jacqueline Baseso McKenzie, Dr. Joy St. John, Executive Director of the Caribbean Public Health Agency, and Mr. Ian Stein, PAHO representative, colleagues from the Ministry of Health and Wellness, colleagues from academia and other stakeholders, chairs of the various sessions of this conference and presenters, organizers of the conference, good morning, everyone. I bring greetings this morning to you and congratulate the Jamaican Ministry of Health and Wellness on behalf of the United States government, the Centers for Disease Control and Prevention, for organizing the 12th National Research Conference 2021. The past 19 months have tested the resiliency of all health systems across the globe. We applaud the ministry's continued efforts, activities initiated, and achievements in combating and containing COVID-19 pandemic here in Jamaica. CDC is privileged with a long-standing technical collaboration with the Ministry of Health and Wellness in many areas, ranging from influenza to HIV, to Zika, to dengue, public health preparedness, and now COVID-19. Just over a year ago, CDC signed a cooperative agreement with the Ministry of Health and Wellness to support the ministry's efforts in addressing various public health needs. We have seen the fruits of this collaboration in some areas, such as the strategic information, data reporting, laboratory, and HIV/AIDS. For example, we have now seen a number of facilities in Jamaica that have reached or close to reaching the third 90 of the UNAIDS goal around HIV viral load suppression. Facilities are now empowered and are using data to inform their programming and decision-making. This is a result of a combined effort from the Ministry of Health and Wellness central level, the regional health authorities, and our implementing partners on the ground. In the areas of COVID-19, CDC, as part of the United States government partnership with Jamaica, has supported the response in combating COVID-19 pandemic with over $2 million. This includes strengthening the emergency preparedness, emergency operations center, lab diagnostics, surveillance, infection prevention and control, and genomic sequencing and surveillance of COVID-19. We funded and partnered with PAHO to enhance Jamaica's emergency disaster management and special services response to COVID-19. And we are currently working with the ministry to support the vaccination rollout in special sites and hard-to-reach areas through the rapid response teams. We have also collaborated with the University of the West Indies, University Hospital of the West Indies, to investigate and describe the clinical characteristics and outcomes of COVID-19 among patients admitted at the University Hospital of the West Indies. Some findings of such research will be presented during this conference. The theme of this 12th National Health Research Conference, COVID-19 Year in Review, a multi-dimensional perspective, is well-fitting given the tremendous stress on our lives and livelihoods COVID-19 had across the world, including here in Jamaica. It is of critical importance to have a forum such as this conference to provide the opportunity for knowledge and experience sharing. There is a wealth of data and knowledge that have been collected and analyzed by the Ministry of Health and Wellness and other stakeholders over the past year that can be used to inform planning and decision-making in the country and globally. The lessons learned can also be shared with the global scientific community. The research areas that will be discussed and covered during this conference are indeed of critical importance. We have gained a wealth of knowledge, as I mentioned, about the virus that caused the COVID-19 pandemic and its impact on individual and public health since the last conference. And we continue to learn every day. However, a great deal remains to be understood. COVID-19 has impacted almost every aspect of our lives and health systems, and a holistic approach will be needed to address the challenges and of the aftermath. We see its impact on health, including mental health, education, national security, NCDs, management, and violence in all its forms. In the area of violence, CDC, through funding from the PEPFAR program, is supporting and collaborating with the PIOJ, relevant ministries in the country, and other stakeholders to implement a violence against children and youth survey. It is worth noting that we have witnessed tremendous scientific advances in response to the pandemic, from diagnostic capabilities to therapeutics and vaccine development. And we should capitalize on these advances to not only address COVID-19 pandemic, but also to address vaccine development for HIV, for malaria and other diseases, and to be better prepared, as the CMO mentioned earlier. And that will impact millions of people around the globe. So I would like to end with congratulating Dr. Karen Webster-Carr and Dr. Grant and the remaining organizers for the conference. And I look forward to the presentations and discussions about the great work taking place here in Jamaica. And I thank you. Over to you.
Thank you very much, Dr. Farouk Dede. And you're getting applause from this side of the world. You mentioned, and so too did the speaker before you, Dr. Joy St. John, that the various research topics were so important. I want to acknowledge some of them and share them. Here's one: COVID-19 pandemic and vaccines, a Jamaican perspective. I can't wait to hear what that is about. Then the COVID-19 pandemic and the elderly. I have a little challenge with that. My mother, who's 93, is elderly. I'm a senior citizen. Panel discussion, men's health, a multidimensional perspective, and there's just so much talk about whether or not it's a vaccine that will affect that particular member, or it's not taking the vaccine that will affect the particular member. Then there's big data and data science, because this thing is big, it's large, it's massive. Coping with COVID-19 and the vulnerable communities, persons with disabilities, the elderly, persons on the street, the homeless. So, you know, we just have to think and work around these, and these topics are so important. And of course, a panel discussion on gender-based violence and COVID-19. Some of the research or the reports that we've been having point to the fact that gender-based violence during COVID-19 seem to have been on the increase. More on that anon. We now move to our next presenter, and this presentation will come via video. Mr. Ian Stein, the PAHO, Pan American Health Organization, the World Health Organization representative for Jamaica, Bermuda, and the Cayman Islands. And now we listen to Mr. Ian Stein.
Thank you, Ms. Ellington, Master of Ceremonies. Dr. the Honorable Christopher Tufton, Minister of Health and Wellness. Dr. Jacqueline Besesor-Mackenzie, Chief Medical Officer within the Ministry. Dr. Joy St. John, Executive Director, the Caribbean Public Health Agency. Dr. Vero Dede, Acting Deputy Chief of Mission and Director of the Caribbean Regional Office of the Center for Disease Control and Prevention. Members of the media, ladies and gentlemen, good morning. I'm pleased to join you for this, the 12th Annual National Health Research Conference, and bring greetings on behalf of Dr. Carissa Tien, the Director of the Pan American Health Organization and the Office of the Americas of the World Health Organization. Conferences such as these facilitate discourse on current health findings and identify innovative opportunities from the data presented, effectively enabling positive change within Jamaica's health sector. This year's staging under the theme COVID-19 Year in Review, a multidimensional perspective is therefore exceptionally timely. COVID-19 has made it clear that research is a key component of the pandemic response, specifically the urgency to conduct research to find safe and effective interventions to prevent and treat COVID-19 and guide every aspect of the response. PAHO is committed to strengthening regional capacities to conduct research. We have developed guidance to rapidly conduct ethics reviews during the pandemic and enhanced research transparency. Ladies and gentlemen, we at PAHO continue to oversee ongoing research in response to a high volume of emerging evidence and address a very challenging topic in our region: the use outside of research settings of interventions that have not been proven safe or efficacious for COVID-19. PAHO has also provided training for researchers, research ethics committee members, and health authorities, and facilitated dialogue to reflect on the lessons learned and the pending challenges to catalyze COVID-19 research. Yet we are aware that research is a social enterprise. Trust in research among the population is essential, and health research necessitates research participants. PAHO has therefore developed tools to engage and inform the wider public and the importance of contributing to research. Let me underscore a key message. The impressive proliferation of COVID-19 research has also highlighted the need for ethical standards for research. We strongly encourage and support the Ministry of Health and Wellness's efforts to strengthen a national research ethics system by developing a law. While we understand that the pandemic led to a pause in this valuable project, we encourage the ministry to resume this effort because COVID-19 has stressed the essential role of ethical research. I want to reiterate PAHO's commitment to supporting the development of this law to meet all the research ethics indicators of the organization and catalyze ethical research in Jamaica. The PAHO WHO strategy for universal access to health and universal health coverage recognizes that a health system that works for all must systematically and sustainably strengthen national information systems for health. The health system must also ensure that decision-making processes consider ethical, cultural, gender, and national perspectives that are anchored in evidence. This overarching strategy has guided the work of the PAHO country office in Jamaica. Since the start of the COVID-19 pandemic, PAHO's technical cooperation in Jamaica has been informed by the WHO COVID-19 Strategic Preparedness and Response Plan and the Health Emergency Disaster Management Framework. We continue to support the ministry in developing national health sector responses that emphasize surveillance, laboratory diagnosis, and points of entry, which serve as hubs for information sharing and limit the cross-border transmission of SARS-CoV-2. As we enter the next phase of the pandemic response, PAHO remains a partner to the Ministry of Health and Wellness in building a research agenda that prioritizes current health challenges and those that are projected to result from the individual, community, and national realities. We anticipate a successful staging of this year's annual National Health Research Conference and commend the Ministry of Health and Wellness and its hardworking team on its commitment to responsive and innovative health strategies. Thank you so much.
Thank you so much, Mr. Ian Stein, and we thank you for the continuing support of the Pan American Health Organization and the World Health Organization. You know, this conference, I'm reliably informed, is being staged in this manner for the very first time in terms of an extended opening ceremony and the inclusion of musical presentations. We are going to go to the first one at this time. I want to introduce you to a young woman who's 18 years old, who attended, who's a student rather, at the Northern Caribbean University. Her parish is St. Mary, and she's been on the national stage for a number of years, even though she's just 18. She has performed for the Governor General, Prime Ministers, and other high-ranking officials. But what is particularly interesting about this young lady is that she has entered multiple national music festival competitions in Jamaica through the Jamaica Cultural Development Commission. And for the first time, we now have someone titled the 2021 JCDC Jamaica Gospel Star winner. Could you help me welcome Erica Lumsden?
Testing. All protocols observed. Good morning, everyone. We have lost so many as a result of the COVID-19 pandemic. And there's so many families that are still hurting. Families have been torn apart, and there's still many that are fighting for their lives. Today, I want to encourage us all to never forget those that we have lost and never forget the way we were.
What's too painful to remember? We simply choose to forget. So it's a laughter
Thank you so much, Erica. Just the medicine I was looking for this morning. What a fabulous voice. I think we just need to show our appreciation one more time. Thank you, Erica. I noticed you chose, just a moment, Erica. I noticed you chose Northern Caribbean University. Are you doing music?
I am now.
You are doing music at
I'm
Northern
also doing Spanish studies.
You're doing Spanish,
yes.
but you are doing their music program as well, I
Yes, I
hope,
am.
because you know they have an outstanding music program there.
Yes, thank
Okay,
you.
You're welcome. Man. If music be the food of, play on. Give me excess of it. That's everything the appetite may say. Look here, no, don't start me this. Rather, let me go back to English, seeing that we do have people from other parts of the world. We have 2 languages in Jamaica. May I just share that? There's a Jamaican language, and there's English, which is our official language. So I mean, did I tell them, say that we have 2 languages? Yeah, so. Just want to understand, say, it really talk in a 2 different way. Right. Let me, before I bring the minister out, because you know he's just going to steal the show, I just want to speak of some scientific presentations that will happen during these 3 days. Dr. Tamara Thompson will do clinical features and outcomes among cases of SARS-CoV-2 infection in Kingston, Jamaica, a retrospective cohort study. Then Ms. Ashley Boyne, pilot study on pregnant adolescents and adults' reproductive concerns and mental health during the COVID-19 pandemic. Then Ms. Janelle Anderson, technology acceptance of mobile health apps for patients with non-communicable diseases during the COVID-19 pandemic. It seems to me it's just going to be a brilliant conference, just addressing so many important topics. And Minister, I said you're going to steal the show. You cannot disappoint me. So could we just welcome the Minister of Health and Wellness for Jamaica, Dr. the Honorable Christopher Tufton, who will address us this morning for the opening ceremony.
Much, Madam Chairperson, and I believe our special item from our young, I'm trying to recall the name, Erica, would have taken the show already. So anything after Erica will be an anticlimax. Anyway, I want to thank you very much, and good to see you as usual. And I agree with you. No one could ever put you in a senior citizens category. You remained young for the many years that I have known you. Doing something right. Distinguished ladies and gentlemen, let me recognize, first of all, our specially invited guests, some of whom spoke earlier, Dr. St. John, Executive Director, Caribbean Policy Health Agency. Good to see you, Dr. St. John, and thanks for those important words. Mr. Stein, the country rep for PAHO, WHO, Dr. Dede, Director, Caribbean Regional Office Centers for Disease Control. And in our audience here, of course, we have our Chief Medical Officer, we have our lead epidemiologist, Dr. Webster Carr. You feel her even if you don't see her, because she's the statistics lady, right? The modeling lady with her team. And so important is that function in the ministry. Other members of the ministry who are here, those online, distinguished ladies and gentlemen, one and all. So I want to join in commending the organizers of the 12th annual research, National Health Research Conference 2021. Anybody who knows me, and I believe the health team would be fairly familiar, given that I've been around for about 5 years, would recognize that I am very big on research and data. In fact, my communications team will tell you that if they take a brief to me without data to support ideas, I give it back to them, right, Petre? Because I believe that you must speak with supporting documentation and supporting information and supporting data. So this, to my mind, is right up my street. I'm an academic by profession, or one of. I taught at the university for many years, and it's so important to me that we use data to make our case. And what a case we have to make in public health. We are in an era when we are challenged by so many alternative views. Some may even refer to it as alternative facts, where there are so many eminently qualified by virtue of exposure to the World Wide Web. My colleague in Trinidad, Minister of Health, says there are so many PhDs in Instagram and Twitter and Facebook, PhD in Facebook. Everybody draws information and they make it and quote it as if it's authority and rarely questions the source of that information. What it really does, and there are upsides, of course, to having access to the World Wide Web, don't get me wrong, but what it really does is it makes our case that much more harder to prove in terms of best practices in public health, in terms of the prevention message, in terms of the curative message, because there is always, and I say this quote unquote, an alternative fact. There's only one fact, right? But there are always some alternatives that claim to be facts. And so the research program, the research agenda, really is critical because we are now competing with so much more than, let's say, 30, 40, 50 years ago, when we could use the one means of communicating, or two or three. We now have an unlimited number. So I really want to endorse and support this annual event. And I want to do so in the context of the fact that we have Dr. Webster Carr now awarded at least 4 research papers through the recently announced, recent meaning a year and a half or 2 ago, the National Research Wellness Fund, where we have put up $50 million to any relevant research proposal that will assist the work of public health. And I know that we have awarded that first tranche of $50 million to 4 research proposals, and I'm hoping that that is going to continue. And this is intended to incentivize relevant research, because ultimately we need to be in a position to make the case, make the argument in terms of where the need is. There are, you know, I was looking at the papers to be presented, and I heard Madam Chair speak to the many research papers around COVID, and justifiably so, given that COVID has dominated the space over the last year and a half, and likely to in many years to come. There are so many areas that we need to cover, and I'm not going to pretend to know it all, but from my vantage point, just observing from the standpoint of trying to assist in making that case of best practices in public health, I have come across a number of areas that I think are important, both in terms of the approach or the process, but also in terms of the topics, the areas that are relevant. And many could be grounded in the COVID experience, given that that is the most relevant that we have had to confront from so many different perspectives. The issue of NCDs, for example, continues to dominate, and COVID has only reinforced the need for work around lifestyle-related diseases. In fact, when you look at the data around COVID and the fatalities, those who have succumbed to the COVID virus, it's clear that the vast majority are persons that suffer from comorbidities, those who have been hospitalized, those who have unfortunately passed. And it tells us that our health profile still represents our biggest advantage or biggest vulnerability. And how we choose to live our lifestyle as individuals, as a collective, as citizens, will ultimately determine our demise and the fashion of our demise. COVID, this was a great and is a great disruptor, but even before COVID, whether it was dengue or something else, the fact is that your illness profile and your lifespan And the quality of life that you live largely depends on how you live it. And so I continue to emphasize the importance of prevention as opposed to cure as a critical part of public health. And in so doing, encourage our researchers to spend some time or more time in combining the behavioral sciences with the clinical sciences. I am a social scientist by training. I'm not a medical scientist. But I believe that behavior and nudging and encouraging behavior, whether through moral suasion, through policy, or through law, is not solely a function of the clinical space. It is also a very important function of the behavioral. And that combination, to my mind, is needed now more than ever. And one of the things I'd like our researchers to do is to partner, to the extent that we're only clinicians, or do clinical work. And I know you have your behavioral economists here in the room and so on, or online as part of our policy unit. But it's to see how we can combine those two efforts, because going forward, it is going to be more important than ever. Now, we have tried it in the ministry. We have done a number of things. Our physical activity and our health education program, Jamaica Moves and so on, was intended to try and influence behavior. Our Better For You menu in restaurants to nudge people towards more healthy consumption. That's all an attempt. Our front of package labeling that we're pushing to give consumer greater information so they make better choices. All an attempt at trying to encourage healthier lifestyle, because that is still the most significant risk that we face in terms of how we proceed as a society and the cost of health, both to individuals but also to the society as a whole. There's another element that I think is so important as it relates to the research agenda, and it doesn't speak so much now to content as it does to advocacy. As a product of the university, or a few universities, but as a faculty member, I've always been critical of the disconnect at times between work that is done, where significant effort and resources put into the work, and it's announced with a grand, and there's a lot of excitement around the work, and very little thought goes into how we advocate for the best practices and the conclusions of the work that is done. Advocacy is as important as the work that you do. Otherwise, your work qualifies for the shelf. And those who you hope to benefit from the work don't know that the work exists in the first instance. Or if they do, they know too little to understand exactly how it can change their lives or impact their world. And, I have long concluded that the credit for research should not be a function of the academic journals that you get published in a developing country context, which unfortunately sometimes is what is applied in strict academic terms to who does good work, the extent of your first tier and second tier journals. When you're in a developing country context like ours, your credit should be given based on the application of your research to the challenges that you face in everyday life. I am one for applied research. I am big on applied research because that is the relevance of our context. We need to solve problems, and we need to help people, Jamaicans, communities like ours, regionally, like CARFA's work, to solve problems. In this instance, helping people to live better lives, better quality lives, eating right, managing their alcohol intake, getting their regular checkup, taking their medication through to the end so they don't get into antimicrobial resistance, resistance to antibiotics, and I could go on and on and on. You all know all of this, right? Which, to my mind, makes the advocacy component and the application component so important to the research methodology and the write-up. And I give far more credit to those individuals than I do to those who get published in the New England Journal of something or the other. I don't know. CMO knows those medical journals, right? You're in a couple of those medical journals, right? But I want you to understand what I'm trying to say. I think it's very, very important, the advocacy component. And so, as minister, and I know I'm the chief flag bearer of policy, yes, so I'm expected to talk more and to take on controversial issues. I don't have a problem confronting, stakeholder interests that I think may need to strike a balance between their own interests and the interests of public health. That's why we took on sugary drink in schools. That's why we take on tobacco. That's why we take on alcohol abuse. And I understand that you're going to get pushback. And one of the reasons why advocacy is so important is because you cannot de-emphasize advocacy when you have to confront others who place a lot of resources and efforts in their own advocacy, whether through advertising or the promotion of their interests and their lifestyle. And so you have to be prepared to engage in constructive conflict at times. I don't mean licking down anybody and fighting anybody. I mean making your case grounded in the data, but being persuasive, sufficient to establish and sufficiently compete in order to get the job done. And so I would love to see a research paper on best practices in advocacy in public health. It sounds strange, not true? Sounds like it don't make no sense. But to be honest with you, I think we need a whole heap more of that. And I'd like to see, is there a protocol where when you finish your work, you ferret out the practical application aspects of it, and you develop an advocacy program for the work. I want to see you on the platforms talking about why it is important to do this and why the evidence support it. And when others are talking contrary to your conclusions, you must be willing to face them down and challenge them. Be bold. Otherwise, you're going to get overrun. And frankly speaking, we are being overrun in several aspects of our public health best practices. We are being overrun. That's why we have a population that is so chronically ill. That's why our immunization numbers are falling. And by the way, this is not a Jamaica problem. I think it's a regional problem. It's a global problem. I think the WHO, CARFA, CARICOM, we have a bigger elephant in the room that I believe COVID has also reinforced for us. I say a couple of other quick things on the research agenda as I see it and the process. I think COVID has taught us the benefits of preparing for the unexpected. And I think coming out of the COVID experience, yes, it's a 100-year experience, we must now go to the drawing board, and research should now focus, to my mind, on how do you refine your plan to deal with eventualities that don't happen every day, but could happen. Luckily for us, we had a disaster risk, I don't know what it's called officially, CMO, but that disaster plan that we pulled together and kind of pandemic plan, right, that we tweaked. And it gave Jamaica a big advantage because we were able to assess COVID-19 long before the first case came here and started to prepare long before the first case came here. And believe, when many may not accept or realize, but Cabinet took a decision to ban flights from the end of January. The first case of COVID came the 10th of March because a decision was taken, guided by the research and the programs that we had, that we needed to delay the entry of the virus and prepare the hospitals, prepare the population, etc., etc. And I think there may be lessons to be learned now that we are so far advanced in the virus. So the research around COVID must now look at how we move forward in terms of learning from that experience. Because COVID over time will dissipate, or certainly not be as much of a threat as it is now. But there may be another SARS, God forbid, virus that's emerging. It's inevitable. It's just a matter of when. Hopefully not in our lifetime, but we have to prepare for it. We have an obligation. I think the evidence-based risk management is very important. And I want to commend Dr. Webster Carr. This is her event. I really want to recognize her and her team. And I want you to give her a round of applause, and the team. Because one of my proud moments as Minister of Health and Wellness is the extent to which, when I rise to speak, I am armed with the data. Well, I said it earlier. And Dr. Webster Carr and her team, Jamaica has an epi unit that, to my mind, is second to none in the region and perhaps in the hemisphere. They apply themselves, they do the modeling, they look at the data, they put it in ways that even I want it to be put in. Right? I called Dr. Webster, I said, listen, look at it from this angle. Give me that set of data. Dissect that, extrapolate that, model that. And, you know, I'm a part of the executive arm of government, so I am required to go there armed with information, especially in a very unpredictable scenario, and they have never let me down. And while I commend you, the issue now is, what are these lessons we have learned to even make us better? I think that we can always work to be better, even though we have done so well, but the real issue here is that you must have the capacity to build around the data that is available. The other point to my mind, is the whole issue of partnerships. We couldn't survive COVID without partnerships. And we have some partners online, some of whom have spoken. We have to reinforce the strength of partnerships, not just regional, international, but local. I believe that for too long we have built policies in public health as if we're in a silo, of a series of silos, even as government. I'm not talking about my government or this government or that government. I'm saying as a country, you can't build out the kind of growth and development that you need if you don't recognize the interrelatedness, which is why I speak to behavioral versus clinical and why it needs to be connected more. But COVID has taught us that one health issue can ground your entire population, as it has the world. Now, what does that tell you? It tells you that you can't do research that is purely clinical without factoring the implications of everything else. And it's such a wide sphere, which is why you have to consult and do cross-discipline and multidisciplinary interrogation of your research in order to get the kind of effect, particularly if you want to make it applied research. The other one is communication. We have spoken about that. It's so important. COVID has taught us that if you don't communicate in a crisis, you create greater panic. And in today's world, communication is so important. Can I tell you that when I came to the Ministry of Health, I got the impression that we were afraid to communicate with the public. There's almost a code of secrecy in public health. And I suspect that it has something to do with the historical perspective of patient confidentiality. Those things are important, of course. But I got a sense that there was a gag order on senior public health officials. You know, they thought the media was their enemy, for example. And hey, we live in a real world. The media is going to challenge and probe, and in some instances they will go for headlines seeking, you know, what should I say? Sales-seeking headlines, put it that way. Market-seeking headlines. Sensationalism, right? It's par for the course. You're going to get that. But you cannot have assumptions around matters of importance, life and death matters, when you have the capacity to clarify or to contradict or to overrule or to provide the data. It don't make sense. We have to, no, there has to be a process to do that. You can't have everybody talking all over the place, but the communication is important, and even research around that, how you communicate. I had 2 weeks ago, I had a discussion with a highly qualified clinician around a particular matter to do with COVID. I won't go into any details of the matter or the individual. But after the person explained to me the concept, I had to say, okay, can you tell me back in English, in simple English, so I can understand it, right? Because the truth is, you can be as complicated as you want, and accurately so, reflecting all the terminologies, and it goes nowhere beyond yourself. And so communication clearly also has the simplicity component. The simpler the better, no matter how qualified we are. But the art of communication is to be as simple as possible. The other, and I'm going to be finished soon, right? But I think these are important. I want to put it on. I was given the main speaker, right? So I was given an extra, I can take an extra 5 minutes. Leadership and research must be intertwined, because ultimately we are leaders in our own right. Public health must provide leadership for good health practices. And you must never feel intimidated when you have the facts about what you stand for. You must be bullish about it. You must defend it, and you must talk about it, and you must be willing to challenge those who have alternative views or alternative facts. I will challenge you as the CMO or any clinician or permanent secretary on their views. And their views are far more advanced in terms of clinical work than I am. And I bring my behavioral thing to it. And I will challenge, and I'm going to challenge hard, right, in a particular context. I don't want anybody to back down on their views. At some point, we come to a happy compromise, but it serves the greater good. But you can't shy away from someone because they have a platform that maybe appear to be bigger than yours, and they are raising their voice on that platform that is overpowering you in terms of the volume, the intensity. You must be prepared with the data and the research to drive that. The only other thing I'll say on this is that we need research to look at how we build resilience in public health, now that we have had the COVID experience. I would support any research that is properly put together that seeks to look at public health and project in the years to come, coming out of the COVID experience. And there are critical components of that. There's a technology component. One of the things that COVID has taught us is that technology does and can make things a lot more efficient. And we're boosting now our technology capacity. As you know, yesterday I announced the multi-million-dollar program to arm our health centers and hospitals with health information system, which will allow patient records to be digitized, summarizing patient history, making earlier decisions, that sort of thing. And I really would want to see us explore things like the telemedicine, self-monitoring through applications that you put together. How do we help our society to lead better lives, but also to control illness, to control their health profile based on the technology, and to treat with them quicker. We need better training or more efficient training coming out of COVID. COVID is going to require significant capacity adjustment. One of the things I'm proud of in public health, Jamaica, and we often get compared with other jurisdictions without the context being fully appreciated, is the effectiveness of our primary healthcare system. Our primary healthcare system really gave us an advantage in the COVID response. And sometimes people say, boy, I see in the markets up north that they're doing things that way and that way and that way. And nobody appreciates that we have a primary healthcare system that they don't have. And therefore, we can do certain things particular ways. They have to do it a particular way. So the context sometimes is missing. I know the CMO is working on bolstering the primary healthcare process. I'm looking forward to that. I think we all should, because the primary healthcare system and the COVID response has been one of our strongest features. Things like contact tracing and quarantining and, Nurse Shecklewood and those people were very important to the process. Am I wrong? All right. Give them a round of applause then, no matter they feel good. I don't know if any of them are represented in here. But I know I could, when I go into an area, I was the sort of Ghostbuster of COVID. You ever watch that movie? Anywhere COVID outbreak, I run down there, right? Much to the dismay of people who were close to me. Even the same one, PSA, you're the minister, you're not supposed to go indoors. I said, no, man, you have to go down there. And you know who I always sit down there? The primary health care nurse, the community health aide, and them walking through, and them going to people's house, and them veranda, them collecting data, and them writing up at great risk to themselves and their families. We must celebrate them. And we must find ways to enhance their impact on community, because lifestyle is going to be about community engagement. If you want to nudge people and change people. Healthcare financing is another big one. We're just not going to be sustainable if we continue in this road. We have started some work on national health insurance. It would be good for some of the research to look at how do we finance public health going forward, because it's unsustainable on the current trajectory. You know, some of these drugs that we purchase are so expensive and so on. And then finally, I say it 3 times because it is going to be the final. I think there is a case to be made for the review of, and I know my colleagues at the regional and global level are online, for a review of multilateralism and its approach in global public health. And Jamaica has always been a very strong voice on the world stage for issues that we feel are of importance, not just to us, but to others. And I would love to see us show some leadership and contribute to the discussion around how we have approached a sort of multilateral approach to managing best practices in public health. You know, so whether it's CARFA and the capacity of CARFA and how we can improve on that by creating stronger linkages and networks around some of the functions that we do. Jamaica is a particular place in the region, and we can perhaps offer more. I don't know, I'm just saying, right? Whether it is PAHO and WHO and what they do. I mean, there are some features of COVID, to my mind, that really ought to be brought to the front as a discussion point, like vaccines and the distribution of vaccines. I mean, it boggles the mind, for me anyway, that the message around the importance of equity of access to vaccines seem to have been lost somewhere in transmission, where some countries who could afford it stockpiled it to multiple times their population, and others just didn't have it at all. And then when we get it, it has 1 month expiry date, and then we're accused of not disposing of it in time. It is a delicate subject, but it is a subject that requires a conversation, and I think to some extent, the research must gather that data to help to influence that. There are other things that are very positive which should be reinforced. I mean, the approvals process around vaccines, efficacy is very, very important. And the role of WHO, for example, how do we improve on that and so on. I believe that we have the capacity, just as anybody else in the world, to play a role. In a sense, we have a special opportunity at this point in our history in public health. The world has never seen this, not in our lifetime. And we mustn't come off of the bridge, come off of the stage unless we leave something for somebody to ponder on for the generations to come. So pick out something out of it and make a contribution, even if you have to challenge the status quo. Because the best time to change the status quo is now. After this is over, everybody gone back to normal, you know. And we get complacent again, unfortunately, till another crisis comes up. So don't waste the opportunity in the crisis. Enjoy your research program. I'm going out of town. This is why I'm dressed like this. Well, I always dress like this, but hope it's not offensive to anyone. But wish you all the best and look forward to some of the papers that you present. Thank you.
Thank you, Minister. You raised some very important points. And let me just thank Trishana Forrest. That's the name of the young lady who has been ensuring that this lectern and the microphone stand are sanitized. Thank you, Ms. Forrest. Minister, thank you. Behavior, advocacy, partnership, communication. And see, that is my area, communication. I want to just take 10 seconds to speak about cultural context when we think of communication. So what might work in the UK or the United States of America could work here, but may not be as efficient and as effective here. Language usage and choice, very, very important. And I know you know, because I think I sent you way back. I don't send you anything these days because you're so busy. But the term jab was, for me, problematic, right? And also for some of the older folk, you know, we have to be careful that we speak with them and to them with a language that will encourage them. And just that term alone for me kind of bothered me. The UK used it, or the Americans use it, but is it really as effective here? You know, just raising it. I know you know I don't mean anything. I'm not dissing you. I'm just raising it. Just raising it. Because it has a negative connotation in our cultural context, particularly with older people. So one size don't fit all. That's what I am in fact saying. But you raise this important point. The last thing I want to talk about is the research that you can apply. It's so important. You know how many wonderful pieces of stuff in libraries, in universities, and nobody don't know about it. I agree with you, so you have support from this side. Ladies and gentlemen, we're going to make some presentations at this time, and this is coming out of last year's theme, which was the COVID-19 experience, adjusting to the new normal. Minister, you are the person with responsibility for making the presentations. There are 5 people. 2 are not able to be with us this morning. Let me mention them first. Best Student Poster Presentation, Dr. Kimberly Somerville, unfortunately is absent, but I think we ought to recognize her and her work. And Most Impactful Oral Presentation, Miss Tiffany Butterfield, is also absent. So the persons, yes. May I ask Minister to come forward at this time and ask Mr. Kevon Graham for Best Oral Presentation. I think the cameras would want you more center, or where are you needed? Sorry, I'm not instructing you. You tell me where you're needed. Direct over here? Okay, fine, great. Just want to make sure. Yes, put on your mask, sir. Mine is on the table right there. As soon as I'm done, I'll don it. And Dr. All right, let me just do this. Congratulations. Dr. Karen Webster-Carr, I just cannot make out people with masks. And that is why I did not realize you were seated. My sincere apologies, because you've done so much work in this country. I'll just tell you this so you don't feel bad. My own rheumatologist, I was in the same space with her, physical space, and did not know it was her. So when I went to see her for my check, we had a good laugh about it. I had no clue. So that's just what happens to me. Now, the Best Student Oral Presentation, Miss Vonetta Nurse. And the final one for this morning, Best Poster Presentation and Most Impactful Poster Presentation, Dr. Leroy Campbell. So I want to ask a question. Is Dr. Leroy Campbell a medical doctor? But you have other talents. Am I correct? You think so? The point I'm making is, friends, and all of us watching, we have several talents and abilities and gifts, not just one. Thank you. Thank you, Minister. Before I go to our final entertainment presentation, and then after that I'll be closing off the opening ceremony, Friday is going to be really exciting. Minister, you're going to be all over the place, but Friday is a big thing. Big, big, big thing. That's their virtual networking on Friday. And breakout room sessions like Jamaica Statistical Society, Caribbean Institute of Health Research, Nurses Honor Society, Micah University College, Violence Prevention Alliance. This is something that for the organizers, very important. Am I right, Dr. Karen Webster-Carr? So I just wanted to mention that. And now we go to presentation. You know, I watched this young lady make her way through the various stages of Digicel Rising Stars. And of course, she has been performing as a professional ever since that time. Rejuvenating, soulful, subtle, crystal clear, thriller are the terms often used to describe her. And she has really grown. Her versatility covers genres such as jazz, R&B, reggae, gospel, and world music. And she now has a very, very clear vision of where she wants to be musically, and she's grown personally. Nikisha Barnes, where are you? She has an EP, Layers of My Soul, with the lead single, Rock of Ages. She's going to rock us at this time. Let's hear it for Nikisha Barnes.
Good morning, everybody. I am going to sing a song that has been carrying me through for the last 2 years. In the midst of COVID, it has kept me, it has covered me, and I hope it does that for you as well. I love you, Lord, for your mercies never failed me, and all my days I was held in your hands. From the moment that I wake up until I lay my head, I have lived in the goodness of God. So my life you have been faithful. See, all my life you have been so good. With every breath that I am able, I will sing of the goodness. This is my part. I love your voice. It has led me through the fire. See, in darkest nights, you were close like no other. I know you as a father, but I know you as a friend. And I have lived in the goodness of God. Can you tell I'm recovering from COVID? See, all my life you have been faithful. See, all my life you have been so good. With every breath that I am able, oh, I will sing of the goodness of God. My mom loves this part. 'Cause your goodness is running after me. See, your goodness is running after me. With my life laid down, I surrender now. I give you everything. 'Cause your goodness is running after me. Can we do that one more time? See, your goodness is running after me. Your goodness is running after me. With my life laid down, I surrender now. I give you everything. 'Cause your goodness is running after me. Has he been good to you? See, all my life you have been faithful. He has done some good things, providing for me in the famine. When the enemy said no, he said yes. With every breath that I am able, I will sing of the goodness of God. I will sing of the goodness of God. All my life you have been faithful. See, all my life you have been so, so good. With every breath that I'm able, I will sing of the goodness of God. Oh, I will sing of the goodness of God. Oh, yes, I'll sing of the goodness of God. Thank you so much. Please continue to be safe and take care of yourselves.
You brought a catch to my throat just now. And you used a word. I don't know how many people understand the impact of famine for people in entertainment in the last 2 years. I tear up because it's been rough. That's what she's speaking about. I got a letter recently from Fab 5. 2 years, no work. And they don't benefit the way others do. It's a real thing, it's a famine. Some of us are able to do other things, but a band, the musicians can't live. The people who lift the instruments can't live. The person who balances the sound can't live. It's a famine. Let's remember that as we go forward. We're going to beat her up, you know. She make my eye them full of water. Well, what a voice. What a growth since 2006 when we first met her on the Digital Rising Stars competition. And then, as she said, famine, I remember the letter from Fab 5. And that's one band. Can you imagine the others? Okay. Friends, it's been an absolute pleasure hosting here this morning, chairing this opening ceremony. It is such an important event that you have laid out and laid on. I wish you success on this very, very important research conference, because all of what you do will benefit the rest of us. Let me remind you of the website. You may, if you have a virtual program or so, or those of you, somebody may have joined and I'm not aware of it. It's our Ministry of Health website, right? Just go on to www. You don't even need the www these days. moh.gov.jm, and you'll find a little icon there with the National Health Research Conference. I'm just asking you to bear that in mind. And to remind us, as Nikisha says, continue to be safe, continue the physical distancing, continue wearing the mask. Mine is right there. I'll don it as soon as I get off and my duties here are done. Sometimes I even start drinking with it on or eating. And then I remember, oh my goodness, life has changed in so many ways. But here we are together. And I just wanted to make one final comment, because I think some of the research will look at mental health. Some people are are having some serious challenges. And you know, one of the things, Dr. Lord, that is causing some people to get depressed and have issues, the fact that our cultural practices exist in a particular way, and when we are saying so long to somebody who's died, that they cannot and have not been able to say farewell in the way that we've been accustomed. So that's a big thing, the death part of things. I didn't want to end on death, but yeah, it's a death knell here now, me done. So, for me, thank you so much, and wish you every success with what you have to do. Just remember, if you're just joining it, it's coping in the COVID-19 pandemic. Vulnerable communities, one of the topics you can look out for, and the communities, we are all vulnerable. This has been the official opening of the 12th Annual National Health Research Conference, the virtual conference, second of its kind, and the more expansive of its kind for 2021. To our guests on Zoom, to our guests on other platforms, we thank you so very much. Walk good. Continue to be safe.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're now wearing a mask, you're now washing your hand, and you now keep the required 6 feet distancing from other people. And what could that really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here why you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Dion Jacksmiller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older like me and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vaccine 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash eyes regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Booking your COVID-19 vaccination appointment is simple. Use one of 2 options. Option 1. Register using the online portal at the Ministry of Health and Wellness's website. Go to www.moh.gov.jm, click Apply Here for COVID-19 vaccinations, and follow the instructions on screen. Enter your mobile phone number. You will receive a text message with a one-time password. Enter it on the site to confirm your account. Fill in the information requested. Choose your parish and a vaccination center there. Then schedule a date and time convenient to you. You will receive a text confirmation with the details of your appointment. Option 2. You may also book your vaccination appointment via telephone. Call the National Vaccination Center at 888-1-LOVE. That's 888-663-5683. A representative will take your information, book you at the nearest vaccination site, and register your appointment. You now have a vaccination appointment. For your first dose, when going to the site, take your TRN and a government-issued identification or letter from a Justice of the Peace. For your second dose, take to the appointment your vaccination card, TRN, and a government-issued identification or letter from a Justice of the Peace. You may ask a relative or friend to help you book your vaccination appointment. Book your COVID-19 vaccination appointment today. Get vaccinated. Get back to life.
Some of we have all sorts of excuses as to why we don't want to wear the mask. The place too hot. We're not used to it. It's not comfortable. Look here now. Wake up and smell the country chocolate. Them excuse they're not gonna make it. You may know the place hot. But you don't want to feel COVID-19 fire in your lungs. And used to. The only way to get used to a thing is with practice. So practice and wear your mask. And as for the start now about comfortable, not no more comfortable. than being COVID-19 free. So find a mask with fit.
COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
From worry over your finances to mask wearing and physical distancing from your family and friends, your concerns about COVID-19 may be many, but you can overcome. Take care of your mental health. Keep a journal. Talk about how you're feeling with someone you trust. Exercise. And yes, take the time to smile.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're now wearing a mask, you're now washing your hand, and you now keep the required 6 feet distancing from other people. And what could that really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here what you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Dion Jax-Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful.
Of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, Don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older, like me, and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
Well, good morning. I would just like to welcome us to the second segment of the National Health Research Conference for 2021, sponsored by the Ministry of Health and Wellness. We want to thank Ms. Faye Ellington for navigating us through the opening ceremony of Day 1. This conference covers a 3-day period. And so at this segment, we're going to be looking at COVID-19 pandemic and vaccines, a Jamaican perspective. When we think of the greatest burden of health, infectious disease, and so vaccines over the years have been able to assist in this process, offers us protection and have our body to build protection against infectious agents, and that includes the COVID-19 virus. To date, the WHO global situation indicated that we had 427,515 new cases of COVID vaccine across the world, and bringing the total up to 253,640,693 persons now being infected with the COVID-19 virus. And there is 5,104,899 deaths. These figures are alarming. COVID-19 is an infectious disease. And so for this segment, we have with us Dr. Webster Carr, Principal Epidemiologist at the Ministry of Health and Wellness, and she's here in-house with us. Welcome, Dr. Webster Carr. We have via Zoom is Dr. Melody Ennis, Director, Family Health Unit, and Professor Peter Figueroa on the Zoom. Our first presenter for today will be Professor Peter Figueroa. Professor Peter Figueroa is the Professor of Public Health, Epidemiology, and HIV/AIDS at the University of the West Indies, Mona, Jamaica, where he has led the development of the Doctor of Public Health program. He was the national epidemiologist in Jamaica and led the national HIV/STI program from its outset in 1986 until 2008. Professor Peter Figueroa has authored and co-authored over 150 publications. He served as Chief Medical Officer from 1997 to 2002. He is the chair of the Pan-American Health Organization Technical Advisory Group on Immunization, and he has been a member of the WHO Strategic Advisory Group of Experts on Immunization and Vaccines from 2009 to 2015. He is a member of the WHO Working Group on COVID-19 vaccines and a member of the UNAIDS Scientific Expert Panel. Please, let us welcome Professor Peter Figueroa, who's on Zoom, that is going to be speaking with us on vaccines. Welcome, Professor Peter Figueroa.
Thank you so much, Carol, for that kind introduction. Are you hearing me clearly and seeing my presentation?
Yes, Prof.
Okay, so thanks for having me. As you said, we have over 250 million confirmed COVID cases globally, over 5 million deaths, and this is assessed as being at least a 20% underestimate of the true number of cases and deaths. At the same time, we now have over 7.4 billion vaccine doses administered. The challenge is that 53% of the world population has received one dose at least, but this represents only 5% of the population in low-income countries. In Jamaica, we are just recovering from our third massive wave of COVID cases, and we now have over 90,000 reported cases and over 2,300 deaths. So this is a significant pandemic, and it is having stress on people's lives and livelihoods. Luckily, most cases of COVID, perhaps 80%, are mild or moderate and people recover. However, 14% are severe and 6% are critical, often leading to organ failure. The case fatality increases significantly with age, perhaps 25% among those over 80 years of age and 12% among those over 70 years of age. And persons with severe COVID often develop long COVID where they continue to have symptoms. The risk of reinfection is estimated to be about 5% at 3 months, and it perhaps even as high as 50% at 17 months. 7 symptoms predict 70% of COVID cases: loss of smell, loss of taste, fever, persistent cough, chills, loss of appetite, and muscle aches. Now, persons who get newly infected with COVID, in 41% of instances, they get it from someone who has symptoms. However, in 59% of cases, the person actually gets infected by someone who is either asymptomatic or, quite commonly, someone who is pre-symptomatic, because in the 2 or 3 days before developing symptoms, persons are highly infective. Hence the importance of wearing masks, physical distancing, avoiding crowds, especially indoors, and hand hygiene. These measures do make a significant difference to help protect ourselves becoming infected. Of course, when there's a massive surge, then you have to look at other social and public health measures. We know that once there's a surge of cases, you're going to see an increase in the number of hospitalizations with severe pressure on the health services. And within 3 weeks of a surge of new cases, you are likely to be getting an increase in deaths. And this has been shown not only, the last data was from the US that I just put up. These data are global data right at the beginning of this year, showing the increased cases followed by increased deaths. The big difference is that we have COVID vaccines, and now over 7 billion doses have been administered. 41% of the global population have received 2 doses fully vaccinated. In Jamaica, we have achieved over 1 million doses, but our coverage is still relatively low, with 1 or more doses with only 1/5 of the population, 21%. And unfortunately, we are lagging badly in our rollout of these vaccines. Only Haiti in the Caribbean is going slower than us. Barbados and Trinidad have already achieved 45% of their population fully vaccinated. Once the vaccines began to be rolled out, you can see that cases declined dramatically. This is data from the US, followed by a decline in deaths. Now in UK, they pursued what is called a 1-dose strategy, where they tried to give more people at least 1 dose, whereas in the US, they made sure that persons got their 2 doses early. In the UK, the decline in deaths was much more dramatic with their 1-dose strategy. And you can see that also with the rollout of vaccines, there was a dramatic decline, not only in cases, but also in hospital admissions. Then we had the Delta variant. The Delta variant is more transmissible than Ebola or smallpox. It's as contagious as chickenpox. Perhaps only measles is more contagious. And this is what has been responsible for a massive increase in cases in June, July in the UK. However, because coverage with the vaccines was over 60% in UK at the time, we did not see the rise in deaths that you would normally see following the increase in cases. In the US, there was also a massive peak of new cases, and this also was followed by a significant rise in deaths, much more so than in the UK, because the coverage, the vaccination coverage in the US at the time with the Delta surge was just over 50%. And this is the number of deaths that they had. You can see at the bottom, the deaths in UK was much less. However, when you look more closely in the US and look at the vaccination rates in the different counties, you can see that the deaths were in counties where there was a low vaccination rate, whereas those counties with high vaccination rates, the rise in deaths did not rise significantly with the Delta surge. And data shows that unvaccinated persons are 12 times more likely to die from COVID than persons who are vaccinated. Now, it is sobering that persons who are fully vaccinated can still get sick and actually die. One study showed that 40% of such persons actually did have some degree of immunocompromise. Also, many very elderly persons or persons with comorbidities. But COVID is not, you have to take it seriously. This is a serious disease. We know the rationale for vaccinating health workers. We've got to preserve the health service. Health workers are at high risk, but they can also infect other patients as well as their families if they become ill. They're on the front line. So it's important that they get vaccinated. And this study showed that, in fact, by vaccinating health workers, you can reduce the risk of them carrying the infection home to their family and household members. In the pre-vaccination period, there was a household event rate of 9.4 persons getting COVID per 100 person years. After one dose, this dropped to below 6. After 2 doses, once the health worker was fully vaccinated, this rate dropped to under 3. So this clearly shows that the vaccines do reduce the risk of infection and transmission. We know that the elderly are more at risk. This is just a curve showing the increase in infection fatality rates with increased age. So we have to get our elderly persons vaccinated early. And of course, elderly people are more likely to have comorbidities. So this is an additional reason for vaccinating the elderly. Now, COVID vaccines have been in development for decades. Research began on the messenger RNA vaccines in the early 1990s. When we had the SARS outbreak in 2003, that stimulated research for a vaccine against the spike protein of the SARS coronavirus that caused SARS. And in 2012, when we had the Middle East respiratory syndrome outbreak, which is due to another coronavirus, that also stimulated further research. So when the Chinese scientists sequenced the genome of the SARS coronavirus 2 that causes COVID, and it was shared internationally, immediately they were able to prepare work on a vaccine against COVID, because they actually were able, some companies were able to take the vaccine, the candidate vaccine that was prepared against SARS, and just adjust the coding. Plus, there's much more highly sophisticated technology now, and US and other governments spent billions to accelerate the COVID vaccine development. Now, the messenger RNA is in these Pfizer and Moderna, it's just encapsulated in a very tiny lipid nanoparticle. And this is injected into the arm, and then it is the phagocytes, white blood cells pick it up, and the messenger RNA goes into the cytoplasm. It does not enter the nucleus, and it produces a protein that mimics the spike protein of the coronavirus. And that is how you get the immune response going. Of course, when they began to roll out this vaccine, they noticed the severe allergic anaphylactic reaction. And this occurs at a rate of about 2 to 4 per million doses. Also, there are reports of myocarditis and pericarditis in young persons at a rate of about 1 per 100,000. But this is a self-limiting condition where you get some chest pain, palpitations, and it usually resolves within 2 to 3 days. This is just a graphic showing the messenger RNA in the lipid bubble. And you notice it does not go into the nucleus, and it just stays in the cytoplasm and produces the spike, the protein that mimics the spike protein. The J&J now uses a non-replicating adenoviral vector. And when that is injected into your arm, it's a similar kind of process. It's a good vaccine. One dose gives 67% vaccine efficacy. That's against any infection or symptoms, and 80% effective against severe disease at 5 months, just one dose. I think they're going to decide to recommend in due course that people get 2 doses, maybe, anywhere between 2 to 6 months after the first dose. There is a rare adverse event, which we'll talk about, the blood clot, as well as Guillain-Barré syndrome, which is also very rare with this vaccine. With the AstraZeneca, it's another non-replicating adenoviral vector that does a similar thing. It's very effective and safe. What people do not realize is that blood clots are less common among persons getting the vaccine than among the general population. And it's better to take the second dose 8 to 12 weeks after the first dose instead of 4 weeks, because you get a better immune response. So for all these vaccines, the safety profile is encouraging. They're highly effective, including against all variants. We do need to alert people that they may have a local reaction, and quite a number of people do get headache, fever, muscle ache, or tiredness, which shows that the immune system is responding. But usually you recover quickly within a day or 2. What we do need to be aware of is the very rare but very serious adverse event, TTS, the thrombotic thrombocytopenia syndrome, where you get a blood clot in the vein, draining the brain or abdomen. However, there are warning signs, because persons who get this condition get severe persistent headache or abdominal pain. And if a doctor sees this in someone who has recently got the vaccine, they need to get to hospital immediately. It occurs at about 2 to 5 cases per million doses. The benefit of the vaccine far outweighs the risk. Persons with comorbid conditions, they're more at risk. They need to take the vaccine. Persons with allergies can all take the vaccine. Only if you have a vaccine allergy do you avoid the messenger RNA. Pregnant, breastfeeding women take the vaccine. The vaccine does not interfere with fertility. There are a few situations where it's better to wait. If you're acutely ill or getting cancer treatment, just recover a bit and get the vaccine. You may need an additional dose if you're immunocompromised. Persons with COVID should also wait at least a month after they recover. They can wait longer if they want. Now, I'm going to round off now, but I wanted to share this slide with you, which on the left panel shows when people are given the Pfizer vaccine with an interval of 3 weeks, compared on the right panel when people are given the Pfizer vaccine and the second dose is given after 10 weeks. The immune response is better with the delayed second dose. And at top are people who are uninfected. In red below are those who have had previous COVID infection, who have an even better response. So that is just like the AstraZeneca. And this shows that vaccine effectiveness against time, it does wane a bit, but when you have, as the bottom graph shows, when the study in the US, when you have the short interval between the first and the second dose, it wanes much quicker than the Canadian study showed, where they tended to wait because they were using a 1-dose vaccination strategy. At 8 months, these vaccines still protect against severe disease and death. In the UK, when they removed all the protocols for non-pharmaceutical measures, you can see the daily average of COVID cases just shot up. And it did cause more severe cases and hospitalizations. So it shows you the importance of at least continuing to wear masks and avoid indoors. We need to get as many persons vaccinated as quickly as possible. Better to vaccinate more with 1 dose than fewer with 2 doses. A longer interval between doses gives better immunity and longer duration of protection. The vaccines prevent effectively against death and disease and reduce the transmission. We need to improve our rollout, get the vaccine into all health centers with a doctor or nurse, all hospital outpatient clinics, train more vaccinators and establish more teams. And we need to facilitate the private doctors much, much better to give the vaccine. Let them use their fridge, let them report weekly, collect the doses weekly, and make it easier for them to participate because people trust their doctors and they will help us get it done. So we don't have a silver bullet with the vaccine, but it is highly effective. We're going to have to live with COVID for the foreseeable future, but getting vaccinated and promoting vaccination offers the best chance to keep safe and restore normalcy. I thank you.
We want to say thank you to Professor Figueroa on taking us through the immune response to vaccination and how it has been very effective. It is safe and cost effective, you know. And just to note, a few points that he has actually indicated is the immune response being better with the increased interval between the first and second dose, and we would want more persons to be vaccinated, and the collaboration with the private practitioners are very important. So at this time, I just want to invite Dr. Karen Webster-Carr, our Principal Medical Officer, a National Epidemiologist at the Ministry of Health and Wellness. She has been in public health for over 20 years. Dr. Webster-Carr has been critically involved in Jamaica's response to COVID-19 pandemic. She leads the team that is characterized with the COVID-19 outbreak in Jamaica, the Information for Action. Dr. Webster-Carr chairs the Essential National Health Research Committee, and I believe this is the same research committee that Minister Dr. Tufton was making reference to, that has done 4 research papers so far. This committee, This committee focuses on research for development and is currently working to advance the national COVID-19 research agenda. We just want to welcome Dr. Karen Webster-Carr to share with us at this time.
Thank you, Dr. Lord. Good morning, everybody. So today I'm going to be presenting mostly Jamaica data. The work that I'm presenting was done by a team, and I'm presenting on behalf of that team, our EPI team that we heard so much about, that continues to work every day, day in, day out. And so I must thank the epidemiology team for their work. So we know vaccination is considered one of the most significant public health intervention, and it reduces illness and death. And it goes further than that. So you can vaccinate some, and it will help others who are under-vaccinated, that they're not given an immune response, or those who we cannot vaccinate. So, for example, in the COVID-19 vaccination program, we can't do the children. So all of us need to get vaccinated to protect those. It also promotes equity if we can get it into all segments of society. It averts deaths, and once it's rolled out and sustained at a rapid pace, then it can prevent even more deaths and hospitalization. And we'll talk a little bit more about it going forward. So this is one US study that shows that even a small increase in vaccination coverage can cause a large decrease in cases, in hospitalization, in deaths. But there can be other there are other benefits. So quality of life, direct medical costs, as well as decrease in productivity loss. This other aspect of this study, this modeling study, showed that if we decrease the time to 50% vaccination coverage, you can save additional lives. This is US numbers. US population is about 120 times that of the Jamaican population, so we can do some calculation. But similarly, we save lives, we save costs, medical costs, and productivity loss, and the quality of life. So it is doing a vaccination program is more cost effective than doing nothing. So if we had to choose between vaccinating and not vaccinating, it's significant. And every dollar we invest in vaccine, we have a greater return. So every US dollar, for example, for Moderna, Pfizer, and AstraZeneca, the return is $13, $23, and $28 respectively. So we have heard that older persons are more at risk for COVID-19 and severe illness and death. And why is this so? Probably due to their weakened physiological and immune response among the older population. And they are more likely to have comorbidities. So we talk about, Minister spoke about being challenged. So he challenged us to look at how we can look at the impact of vaccination on the population. So in doing this research, we looked at some countries who measured, Brazil and the US, the proportionate mortality, and we'll share that a little further down. So in wrapping up my sort of introduction, it's studies that model the feasibility of reaching herd immunity with an effective vaccine is around 70 to 80%, and could be as much as 88%. The more transmittable variants that are occurring, for example, Delta, it requires that more persons be vaccinated, heading towards 100% for herd immunity. It is also the trickle approach, just doing little 1% of the population here and another 1% here. That trickle approach is counterproductive in achieving herd immunity. By the time you vaccinate one, the immunity wanes in another, right? Non-pharmaceutical containment measures such as mask wearing may augment the vaccination coverage to suppress infection rates. And I think that is important in going forward. So we explored the early impact of vaccination on COVID-19 death. Our hypothesis is mortality will fall more rapidly in the elderly population, which was initially targeted in the vaccine campaign in March 2020, March this year. So we calculated proportionate mortality, and for persons 60 years and over, as well as 70 years and over and 80 years and over, and using the difference for the time to calculate the number of deaths that were averted. We also did some age-specific COVID mortality rates. We computed those, comparing persons 0 to 59 and those 60 years and over. So, this is our data, and this is the 14th of November. So older age was associated with increased risk of of death. And we know that older persons were prioritized for COVID vaccination, and persons 75 years and older, that started on March 22nd. And just on the left-hand side of the chart, reminding us of our older population, 13% of Jamaica population is 60 years and older. So far, this is coverage up to yesterday. The vaccination coverage is at least one dose of 23.2, and completed their vaccination was 17.6. And you see the parishes, KSA leads the way in vaccination coverage. When we look at COVID-related deaths and who was vaccinated, so we took from March to, this is data up to the 14th of November, and looked at it. 98.3% of the deaths occurring in this period were unvaccinated. 0.8% were partially vaccinated, and 0.9% were fully vaccinated. So when we look at the vaccination coverage by age, persons in their 70 had the highest rate, followed by persons in their 60s. So this is our proportionate mortality and mortality rates. So if we took the line, you see the red line that represents March, and then some time for immunity to start developing. So we started the calculations from April, and for all age groups, 60 years and above, 80 years and 70 years and above, you can see there was a decline in the proportion of persons in the age group. And when we did the analysis, we estimated that about 558 persons 60 years and older, deaths were averted. So 558 deaths in persons 60 years and over were averted between the period May and August 2021. So in reviewing the deaths every day, we noted something. We noted that there were more, initially there were always more males than females dying. But in recent months, we noted that the number of females seemed to be more. And we plotted that, just the absolute numbers, and look at it. So in the waves 1 and 2, the number of males dying was greater. And when we looked in the third wave, August, we had more females dying than male. So we're thinking, is the change related to the variants in circulation? Maybe we now have Delta predominating, but then we had a new variant in the second wave, of Alpha. So what is it? Is the change related to vaccination? We look at it, well, globally, when looking at it, more females are vaccinated than male. But we drill down a little bit more. So overall, yes, you have more females than male. But then when we look at persons 70 and older, you note that there are higher coverage among males than females. There are less, so this was even for absolute numbers, but we know the population size for male in that age group is a little less, but it was even absolute numbers as well as coverage. So this is a thought. So we did the same calculations over for males and females. We really didn't see any big difference, really. We have to look at it a little deeper. In both cases, there was a decrease. And if we looked at the estimated number of deaths in males and females 70 years and older, there really wasn't a difference in the number of deaths that were estimated to have been averted. But this is what we have so far. It begs more questions. So just remind us, vaccination is important because we have less COVID infection, less hospitalization, less death. Improve the quality of life, less direct medical costs, and decreases productivity losses. And just to say to everybody that we need to move from where we are now with the vaccination coverage to where almost all of us are vaccinated. So get vaccinated, Jamaica. Thank you for your attention.
Thank you very much, Dr. Webster Carr, on that modeling study. Very informative that the proportionate mortality between males and females, that there is no difference in averting deaths. But what we want to do is increase vaccination, increase quality of life, decrease deaths, and decrease the severity of illness. And so we want again to stress the point that vaccination is important. Get vax. All right? Thank you so much. And so let me just remind you that for this segment, we would have had Professor Peter Figueroa, We would have had Professor Peter Figueroa and Dr. Karen Webster Carr. And to just remind you that we are at the second segment of COVID-19 pandemic and vaccines, a Jamaican perspective. So for this the final presenter is via Zoom, and that is Dr. Melody Ennis. And she's a director of the Family Health Service, has been incredibly leading the implementation of the COVID-19 vaccine initiative. Dr. Melody Ennis had been a health practitioner for several years and has also served at the Southeast Regional Health Authority. And so we want to welcome Dr. Melody Ennis at this time, and to say that following Dr. Melody Ennis, we will have the panel discussion where you're free to ask your questions and receive your answers to this segment. Dr. Melody Ennis, welcome.
Thank you so very much, Madam Chair, and a pleasant good morning, everyone. I am going to be just walking you through what has been happening since March 10, actually before March 10, in our preparatory phases for the COVID-19 implementation here in country. I want to share with you just a few highlights looking at our program mandate and the objectives that continues to guide how we function, how we arrived at the business of the target grouping and herd immunity, how we have and continue to ramp up demand for the vaccines, being mindful of their importance in this pandemic, looking at some of the wins. And of course, it would be remiss of me not to speak to the challenges, but right beside the challenges are the things we are looking at for 2022 as we strive at continuous quality improvement. Okay, so at the base of our program, we have a mandate that is certainly aligned to international best practices. Of course, we must look at ensuring that the well-being of all of our citizens are taken care of. And that, of course, is not just the health well-being, but the composite well-being. And as such, we have embarked on the mission of reducing death and the disease burden caused by COVID-19, and to assist in every way to reduce the socioeconomic disruption that occurs or can occur due to this pandemic. Equal respect is a fundamental principle that we have embraced, where the equal moral status of all of our citizens and their thoughts must be taken into consideration in how we execute. Equity, the business of access and the non-discriminatory practices with regards to vaccine allocation as well as distribution, is also a key component. Our activities must be legitimate, it must be guided and continue so to be by best available scientific evidence, and of course, it must be transparent and can be held up to the highest level of scrutiny. The business of reciprocity is important because we must honor obligations to those who bear significant additional risks and burdens due to the presence of COVID in our country. So having these as the foundation, we proceeded with charting our main objectives. Of course, reduction in morbidity and mortality, protecting the integrity, so important, protecting the integrity of our healthcare system, its infrastructure, so that we can have continuity of services. And of course, our ultimate goal is to reduce the transmission of infection in our community by getting to herd immunity. With those, we looked at the target population and how we would roll out the program in a phased basis so that our most vulnerable would be addressed at the outset until we expand into the entire population. So we started out, of course, with our healthcare workers, our vulnerable and priority groups, and then we did some expansion of the vulnerable persons. We then went into the general public, and as we continue into the general public, our mop-up activities for persons who did not participate, who were a part of the previous groupings, are facilitated. Now, when we did our micro-planning, we recognized that it would take about 65% of the population being fully vaccinated for us to get to herd immunity. And we recall the importance of herd immunity. It really is to protect those who, in truth and in fact, cannot be vaccinated. We have a large population as we speak now, or children below the age of 12. We also have persons with underlying conditions which precludes them from getting vaccinated. So we are and still holding fast to 65% of our population being fully vaccinated, and we have set our target or goal at the 31st of March 2022. Now, this is just a sneak into the persons who would have been included in our priority group as ones who should receive the vaccines immediately on entry into country. And that total number was just about 466,085 persons, our healthcare workers at the top of the list, of course, our elderly persons, our non-health frontline workers, persons in our infirmaries, residents and staff of nursing homes, as well as our institutionalized persons. When we expanded the priority population, we included children, 12 to 18 years. We looked at schools as well, persons in the transport and tourism sector, the media, as well as our athletes. Now, as we planned, we recognized that there were several obstacles to vaccine acceptance, and really fear seemed to have head the list. Persons were so fearful of the vaccines being made way too quickly from what they were accustomed to. And this fear was certainly compounded by the conspiracy theories and the misinformation that continues to plague social media. And these ramblings have really and truly confused persons, even those who have over the many years bought in and understood the benefits of vaccines. There were persons, and there continue to be persons with varying religious beliefs that, may hinder, prevent them from accepting the vaccines. Family and friends having their own opinions, especially, of course, those that live abroad. They are counseling and, again, using social media to speak to our population. Other persons simply just don't know why they don't want the vaccine. And a lack of trust in the system, not only of government, but of big pharmacy companies. This business of lack of trust runs deep. And all of these obstacles were unearthed utilizing our focal group discussions, the Blue Dot study that was conducted, and other informal surveys that were conducted among healthcare workers as well as among the general population. So we recognize at an early stage that we really would need to ramp up demand, and the demand generation and communications team, which is a sub-unit of the National Coordinated Committee, began their task of quelling and certainly demystifying and bringing clarity to the vaccines and their purpose. The need for staff empowerment was at the fore, because all of us, irrespective of the position we hold, are viewed as credible healthcare workers, and therefore the information should be the same across the board. We focused a lot on message consistency and media engagement. We had to adapt and create contextually appropriate messages. We know that we get templates from abroad looking at how they reach their population, but we are unique and special, and we have our nuances. And of course, our message has to be real and significant to us here in country. In our messaging, we highlighted the importance of high immunization coverage. Our fact sheets were created, training materials, videos, and posters, and all of this was done with the hope of fostering trust in our system. Our messages primarily looked at safety of the vaccine, the efficacy of the vaccines, how they benefit us as individuals, as well as benefiting the population at large. We assured persons of the phased approach so that they would not in any way feel as if they were left out. It was very deliberate in how we approached the rollout. And of course, we focused a lot on accessibility. All of our messages were packaged for all the platforms, radio, TV, social media, print. We engaged in community sensitization sessions, town hall meetings, COVID conversations. We looked at utilizing influencers as spokespersons to get the message across. Public awareness sensitization sessions were critical to the buy-in to the program, and we continue to air on 8 to 10 radio stations weekly the Let's Talk Vax feature, just giving information and answering questions from the public to allay fears and, of course, encourage persons to get vaccinated. Our sensitization sessions have gone viral. YouTube, Facebook, Instagram, Twitter. We have reached the clergy. We go to the private sector, all the ministries, departments, and agencies, companies, schools, and anyone who is willing to hear us and invite us into their space. We have been willing to do sensitization sessions. We have had several positives in this program since we started. We engaged with the COVAX facility, which really is an entity that was established to ensure equity in the distribution of vaccines, and over 180 countries are involved in this with this organization. Other benefits of being in the COVAX facility is that prices of vaccines are negotiated, as well as there is a variety of vaccines that can be had. So there's a suite of vaccines that is afforded to countries. Our multi-sectoral COVID commission was established to look at ensuring inclusiveness in the country as to how we do the rollout. The support from the Ministry of Foreign Affairs and Foreign Trade is really cannot be overemphasized, as they have participated and continue to lead the bilateral talks so that we can actually access a lot of the vaccines. Several MOUs have been signed. Most significant is that with the private sector, which has allowed us to utilize the private sector vaccine initiative as an avenue of distributing and inoculating our population. The partnership was further cemented with the Facey Commodity Limited, where they have afforded us the opportunity to accept the Pfizer vaccine because we do not have ultra cold storage capacity within the ministry at this time. And that company has been keeping, caring, and storing and allowing us to have the Pfizer vaccine here in country. We have been blessed with access to mobile clinics from private entities. We received our donations of 2 vaccine buses from the Chinese government. Our program has been endorsed by many associations. We have pledges of commitment from various umbrella groups, the umbrella group of churches. We look at support by the trade unions, and of course, the overwhelming support we have received from private companies in partnering with us to host our Blitz activities. All of the talks, all of the lobbying, the advocacy have led to us receiving to date 2,319,290 doses of vaccines. AstraZeneca, of course, taking the lion's share with over 1.5 million. Johnson & Johnson coming third with 216,900 doses. However, we should be mindful of our commitment to receiving several doses of Johnson & Johnson. It's just that it's coming in tranches. And we have to date received just under 560,000 doses of the Johnson & Johnson vaccine. Now, when we started the program, we were limited in a way in persons accessing the vaccines. So we would have started primarily with our fixed vaccination sites at health facilities. We did have a few non-health sites, and we did start to go out early, looking at nursing homes and penal institutions. But in short order, our services increased tremendously so that persons could get access. We started with a bang with our Blitz operation in April. And in all honesty, Blitz operations have certainly taken on a life of their own. We have the car service that we operate at specific sites for persons who are unable to come in to our areas. The private sector vaccine initiative was born, of course, shortly after the MOU was signed, and this entity continues to go into private companies to vaccinate their population. We noted this stress and strain at the national level, what was happening with what was going on the field, and the rapid response team was born. The rapid response team operates out of center, and it facilitates ministries, departments, and agencies being inoculated on site, and it supports the regions whenever they have challenges. If they're short on staff, the rapid response team is available. Our community interventions have increased tremendously. We have partnered with the political directorate to go into communities, reach the people where they are. Our pop-ups have certainly taken off with the acquisition of those buses. So we do rural and urban areas, and of course we operate 24/7. Our private healthcare providers at the larger centers, the hospitals, came on board through a request for quotation, and in all of our parishes with major hospitals, these are and have been on board in offering vaccines to their clientele. Our house-to-house program started in 9 parishes, and we continue to expand that program. Private doctors have been included and are welcome to give vaccines. We conducted a training with over 146 private doctors who expressed an interest, and we continue to await their full take-up and participation so that they can vaccinate their clients who so trust their private doctors. We have also started to inoculate in our clinics, all of our clinics, our public clinics, antenatal clinics. We have started that vaccination. So national access for this program is really at the top of its game at this time. The doses we have to still celebrate. We note that we may not be where we want to be, but we've got to celebrate our successes of how many persons have received a dose of the vaccine, and we have over 1 million of such persons. That really represents 55% of our target population and 35% of the general population. First dose, 30% target, 19% general. Second dose, 25% target, 16% general. Not where we want to be, but grateful, being mindful of all the hiccups that we had in accessing vaccines in a timely manner. Our children, 37.4% have received a vaccine, and 14.6% at this time are fully vaccinated. Our challenges, yes, our challenges are many, but they're not insurmountable in any shape or form. When we look at vaccine acquisition, we noted the limited supplies that we have received from the COVAX facility. Yes, limited supplies based on what we had intended to get at the start. We should have received or will be receiving just over 900,000 doses of vaccines out of the COVAX facility. And we are not quite even at 200,000 doses as yet. So the supplies have been limited. We would have planned, when we're doing our micro planning, we would have planned on the tranched approach of getting those vaccines to be able to roll out better, but that did not happen, but we continue, we press on. Now the vaccines we have received have had a very short expiration date. There's one set of vaccines we received that had just 8 days to expiration. And the team cannot be commended enough for that week of activity where over 87,000 persons were vaccinated. There is also a very tedious process to transfer vaccines between countries. So, you know, Jamaica and Trinidad, Jamaica and Suriname, etc. Very tedious, very complicated, very long process that just really hinders the smooth execution of our programs, not only here in Jamaica, but certainly across the Caribbean. The uncertainty of the vaccine arrivals, the numerous delays that we get, even after receiving documentation. We know that it's not always in the control of the manufacturers. We have to look at the transport system where, due to lockdown, due to this pandemic, flights are limited and the frequency is also affected. So all of those things have prevented us from having the smooth flow of vaccines into country. The administering process is not without challenges. We have moved into the electronic space. We have our AMBER and CompCare system. However, glitches are there. And we continue to work with our international partners to have these smoothed out as quickly as they arise, because they continue to come up from time to time. We have had overcrowding at our vaccination sites, and persons have been disgruntled. Persons have really, really not been able to appreciate the seamless way in which we want to vaccinate. Because of that, we have partnered, of course, taken steps to stop this by partnering with other agencies. The JDF, the JCF has been tremendous in assisting us with crowd control. We've got to talk about the staff. The staff is subject to the same conditions as everybody else with COVID. So there is sickness. There is the business of quarantine. Unfortunately, we have even lost persons from the health sector to COVID. So there is sickness, there is burnout, there is absenteeism, there is the business of fatigue, the depression. It's all there with the staff that, of course, limits and can hinder the administering process. However, our staff has remained dedicated and committed. And as we see, we are vaccinating. We've done our 1 million mark and continuing strong. Other areas of concern to us, vaccine hesitancy. Yes. So the misinformation is still there. Persons still gravitate to what is negative. The myths, we have tried our endeavor best to dispel these myths and present the facts in a way that is understood by the communities, but persons are still listening and believe in social media. The religious challenges that we have with persons and their views, although we have had endorsements from the umbrella group of churches and the hierarchy, there are still those within their congregations at the local level that have challenges. And of course, just offering the vaccines to persons now, they are speaking about their human rights, their ability to choose, to say what ought to be and what ought not to be. We can only continue to encourage them and, of course, let them recognize the importance of being not just an individual, but looking at our contribution to the benefits of the wider society. Media has really been for us a two-edged sword. It is good. They allow us at times to spread the word, to engage. But of course, sensationalism comes in at times, and there are some negatives that may need to be said, but it depends on how it is said. And of course, damage control is never as good as if we do not have that damage at all. So we continue to work with media. Now, financial incentives have been looked at by the government, and they have been met with mixed reactions. Some persons are, yeah, it's a good thing. Others, the vaccines cannot be good. That's why you're giving me a financial incentive or any incentive at all. Something must be wrong. So again, it needs to be balanced in how the messages are communicated. Our ISAVs, which of course are our events that are supposedly attributable to vaccinations or immunization, we have a robust system that is transparent. However, we have challenges with receiving information from the field, which delays how we put out information on closure of these cases. And of course, at times, that can backfire and lead to persons losing confidence in our program. Vaccine preference has been high on everybody's agenda over the last couple of weeks. We have seen where that has gone, the slowdown in the uptake of some of the vaccines we have had, and the significant increase in numbers when other vaccines came into country. Wastage and waste management is something that we are also very concerned about. But as we move into 2022, what are we keeping and what must we do? So as the clock ticks, we're still holding fast to our 65% by the 31st of March. We must maintain access in all the areas as described previously and reach out to other members, certainly of the medical fraternity, to come on board and vaccinate their clients. We hope to increase the suite of vaccines. We have documentation of additional varieties of vaccines coming into country. We want to strengthen the vaccine ambassadors that have started in a few parishes, ensuring that they speak to, on a one-on-one basis of patriotism, harm reduction, the benefits of the vaccines, how it will get us back to being a productive society. We've got to look at task sharing and shifting. We can't continue burning like this. We have to look at how our program can be sustained and integrated, incorporated into all of our other programs. And that will require a review of the tasks that various categories of staff perform, and we embrace mentoring, capacity building, so that task sharing and shifting can become a reality. As we move into 2022, we want to engage in another way our PR team, looking at the Think, Feel, Do framework, which really looks at the why, the how, the who, but it speaks to the cognitive and it speaks to the emotional entities within persons so that they can go to the do stage. So we will be looking closely at this framework and how it can be applied to the messages that we present come 2022. We know that our digital vaccine credential system is poised to come on stream mid to late December. So by 2022, that should be on stream. We will continue to follow the evidence as to how we vaccinate in country. We want to strengthen the business of research here in country. The data we have is invaluable, and it is about time we begin to not rely so much on proxy data, but use what we have, validate our local stance. Advocacy must continue, looking at the approaches that are taken to acquiring vaccines, allocations, distributions, etc. Linkages and partnerships must be strengthened, and in all of this, equity must be a priority. I want to thank you so very much. Over to you, Madam Chair.
Thank you so much, Dr. Melody Ennis, for taking us through the implementation of the COVID vaccine and the several plans we have for the COVID vaccine and ensuring that the population is vaccinated, that we can achieve herd immunity. And you say your target is 65%, and we appreciate that. We've also learned that it's important that all hands be on deck, and the strategy that was used to ensure that all hands involved in the COVID vaccine implementation. We would now want to invite our participants in-house and on Zoom to ask their questions or to make their comments.
Okay, good afternoon. We have two questions, and the first one is from YouTube, and it follows as have we isolated and purified any SARS-CoV-2 variants specific to Jamaica and or the Caribbean?
All right, I'll ask Dr. Webster-Carr.
So we have not received any genetic studies that shows that at this time. Thank you.
Thank you. Can we have the next question?
Okay, this question is from Zoom. If one has been vaccinated but doubts the efficacy of the AstraZeneca brand, can they opt to get another vaccine brand?
All right, Dr. Melody Ennis, can you please take that question for us?
Sure. So at this time, it is not recommended to mix vaccines, and persons are encouraged to take the second dose of vaccine. Several studies have been conducted, and it shows that if there is an extended period between first and second dose, then that antibody response is much stronger. So I would encourage persons to not embark on doing antibody studies after the first dose of any of the vaccines, but to complete the series so that you can benefit maximally from the vaccines that are being offered.
Mm-hmm. Okay, thank you very much, Dr. Melody Ennis. Do we have any other questions? We can invite our Zoom participants to use the raise hand icon.
Okay, we have another question from Zoom. Is the pattern of vaccine preference demonstrated in Jamaica similar to that in other countries in the region? And is the pattern of general vaccine hesitancy the same or similar?
Okay, that one is for you again, Dr. Melody Ennis.
Very interesting question. A lot of anecdotal information we have. So when I speak to the EPI managers in the Caribbean, we seem to have the similar or having similar challenges. Yes, there's a preference because we're all exposed to Western media and we know what vaccines are being promoted in those areas. There are a few of the Caribbean countries that actually went out of the box and they started administering Sinopharm. They've even started administering the Sputnik vaccine. The uptake has been relatively good because they have vaccinated more of their population than we have. But the preference really is for what the Western society is showing to us.
Excellent.
Reasons for hesitancy seem to be along the same lines. However, for us, we really just need to deep dive a little more because we believe that persons just require more information on a one-on-one basis.
Yes, thank you. Is there any other questions or comments that the participants on Zoom or the YouTube would like to share with us? Anyone in the room, you have any questions you would like to ask? All right.
I see in the chat, Dr. Lord.
Yes, thanks.
Someone is speaking to third doses have been bandied about. Are we considering? So, ladies and gentlemen, we are offering the third dose, which is an expansion of the primary series, and that is to a specific category of persons. Those persons who are immunocompromised. They may be those who are on dialysis, those on chemotherapeutic agents, those that have had transplant, persons with very low CD4 counts due to their HIV status. There's a set group of persons that the recommendation is to give them a third dose if they took the 2-dose regime, or a second dose if it was the Johnson & Johnson, so that their immune response can be heightened.
Thank you very much. Is there anything else in the chat, Dr. Melody?
Yes, I see someone asking if we are still going to receive Sinopharm, and based on the documentation I have, that answer is yes. So Sinopharm should be here shortly.
All right, thank you so much. So that is the final one, Doc?
Students who, one more I seen, Doc, hold on. Students who haven't received their first dose, I'm told it's offered at high school or he or she, okay, so you can make contact with your school to see if your school is a site, or your school will direct you to a main site for all those satellite schools. That's one option. Don't ever forget, you can come into our health centers to get vaccinated. Just go online, www.moh.gov.jm, make your appointment, and you can access the Pfizer vaccine, or for that matter, all the vaccines. Can we routinely publish the ISAVI report on the MOH website? We would love to do that. That is our intention, but we have to close the cases. And as I alluded to earlier, there are some challenges with getting all the information so that we can close cases. So we have received today just about over 500 ISAVIs, about 120 have been classified as requiring further investigations, and we have closed only about 24 or 23, 24 of those cases. So we are working to put those on our website to, just to ensure our transparency and to continue building confidence in our program.
Thank you very much, Dr. Melody Ennis, and we want to say thanks to the other panel members, Dr. Karen Webster-Carr, Professor Peter Figueroa. Thank you so much, and we are coming to the close of this segment, COVID-19 pandemic, with the vaccine perspective, perspective on vaccines, and we want to remind you that it's important that you wear your mask, hand sanitization, and keep social distance. With vaccines, we can prevent the spread of COVID-19, prevent severity of illness, prevent death, and this is an important message from this segment. We want to invite you now to look at the posters, the virtual posters on the Zoom, and visit the various rooms that is up for you. Thank you very much, and we want to say thank you to all. We now have a 5-minute break, whereby you will be encouraged to have a restroom break and then return to the next section.
The NHF, an agency of the Ministry of Health and Wellness, has been called upon to respond in so many ways during this COVID-19 pandemic, procuring equipment for health facilities, procuring PPEs, and really providing innovation in delivering service.
The NHF has introduced a number of measures for the safety and convenience of clients and staff. An emergency response team to chart a course of action, reconfiguration of the customer care center at head office for social distancing, cleaning and sanitization of offices, work from home flexi-time and shift systems, and distribution of care packages to staff. Early refills and increased access to medication for beneficiaries, home delivery service to drug-served patients 65 years and older, and mobile pharmacy services in quarantined communities.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're now wearing a mask, you're now washing your hand, and you now keep the required 6 feet distancing from other people. And what could that really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here why you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, roasting with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older, like me, and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine. and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vaccine 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you, your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Booking your COVID-19 vaccination appointment is simple. Use one of 2 options. Option 1. Register using the online portal at the Ministry of Health and Wellness's website. Go to www.moh.gov.jm, click Apply Here for COVID-19 vaccinations, and follow the instructions on screen. Enter your mobile phone number. You will receive a text message with a one-time password. Enter it on the site to confirm your account. Fill in the information requested. Choose your parish and a vaccination center there. Then schedule a date and time convenient to you. You will receive a text confirmation with the details of your appointment. Option 2. You may also book your vaccination appointment via telephone. Call the National Vaccination Center at 888-1-LOVE. That's 888-663-5683. A representative will take your information, book you at the nearest vaccination site, and register your appointment. You now have a vaccination appointment. For your first dose, when going to the site, take your TRN and a government-issued identification or letter from a Justice of the Peace. For your second dose, take to the appointment your vaccination card, TRN, and a government-issued identification or letter from a Justice of the Peace. You may ask a relative or friend to help you book your vaccination appointment. Book your COVID-19 vaccination appointment today. Get vaccinated. Get back to life.
Good afternoon, ladies and gentlemen. Welcome to this scientific session, number 1. And I must commend the organizers for putting on the research conference this year. And thank you for the privilege to be the moderator today. I'm Dr. Kevin Goldburn. And we have a lot of presenters today on COVID-19 and chronic non-communicable diseases. Our first presenter is Dr. Tamara Thompson. She's a consultant physician, infectious disease specialist, and lecturer at the University of the West Indies and USII. She completed her internal medicine residency at the University of the West Indies and thereafter a fellowship training in infectious diseases at the University Health Network, University of Toronto, Canada in 2014. Dr. Thompson is an active member of various USII COVID-19 working groups, and her contribution has led to the development of various COVID-19 operational protocols. At the USII, Dr. Thompson oversees the clinical management of COVID-19 patients. So she is well suited to present to us the clinical features and outcomes among cases of SARS-CoV-2 infection in Kingston, Jamaica, in a retrospective cohort study. Please make her welcome to the podium.
Good afternoon, everyone. Dr. Goulburn, thank you for your warm introduction. And I'd also like to thank the organizers of this conference for giving me the platform to present the findings of our study coming out of the University of the West Indies and sharing it with the Ministry of Health and Wellness, as well as the wider medical fraternity. So the researchers for this study are listed here on this slide, and largely they hail from the Faculty of Medical Sciences and the Caribbean Institute of Health Research at the University of the West Indies. We also have on our research team individuals from the Caribbean Regional Office of the CDC, and their names are listed here. Drs. Kellyanne Gordon Johnson and Dr. Varro Dede. All the researchers for this project are also co-authors on the manuscript produced from the data that was yielded from this study. None of us have any conflicts of interest to report. And so the title of our research is shown here, Clinical Features and Outcomes Among Cases of SARS-CoV-2 Infection in Kingston, Jamaica, and this is a retrospective case series. So why did we decide to conduct this study? So I'll give you a little background here. So you will recall that Jamaica recorded its first case of SARS-CoV-2 on March 10 of 2020, and that patient, dubbed Patient 0, had presented to our very own university hospital for treatment and care. Thereafter, once we got into the phase of community spread, we began to experience recurrent surges of SARS-CoV-2 on our fragile healthcare system. And so the clinicians looking after the patients with COVID-19 at the university hospital began to ask themselves, who are we really treating? And so what's the profile of these patients who are presenting to our hospital? What are the risk factors that these patients present with? And what are the outcomes of concern for these patients? It was important for us to describe this because at the time when our research proposal was being written, and certainly up until today, there have been no descriptive studies of the clinical characteristics and outcomes among Afro-Caribbean patients in the English-speaking Caribbean islands that we've been able to trace in the medical literature. Our team really wanted to fill that knowledge gap. And so we proceeded to conduct a retrospective analysis of adult COVID-19 patients admitted to the university hospital during the first year of the global pandemic. And so our interest was to inform from our study approaches to risk stratification and early treatment strategies in the management of COVID-19 patients and to mitigate against poor outcomes. And so our aims were succinct but very specific. We wanted to describe the demographic, clinical characteristics, and indicators of poor outcomes among hospitalized patients infected with SARS-CoV-2 at our tertiary center in Kingston, Jamaica. So, in our retrospective clinical chart review, we identified 362 COVID-19 patients as being eligible. All 362 patients were admitted to our isolation units at the University Hospital, including our designated COVID-19 ICU. And the time frame, as indicated, was between March 10, when we identified our first case, to December 31st of last year. Patients were identified as having confirmed COVID based on the WHO case definition that we were using at the time. And further, all confirmed cases had an RT-PCR test according to the PAHO testing protocol. We used the CDC EpiInfo version 7 tool to abstract information from our electronic patient medical records, as well as from our electronic laboratory information system at the University Hospital. And then with this data, we were able to use Stata 16 and SPSS version 21 for analysis. We looked at several patient-specific variables, as listed here. Demographic data including age, sex, smoking history, pregnancy, and comorbidities that the patients presented with. We also looked at the range of presenting symptoms for these patients. The COVID-19 severity of illness, we were able to define those using the WHO Severity of Illness Classification tool. And we looked at a number of laboratory variables, as listed here: complete blood count, absolute lymphocyte count, electrolytes, liver function tests, D-dimer, LDH, and serum albumin on presentation. We looked at a number of outcome variables as well, and 7 of these were important to us: respiratory failure, sepsis, secondary infection, coagulopathy, the development of acute kidney injury, admission to our ICU, as well as death. We were able to obtain ethical approval from the University of the West Indies Mona Campus Research Ethics Committee, as well as the CDC, before we started our data collection. And so this slide summarizes data for age, presenting symptoms, and comorbidities for our study population. So of 362 patients with COVID-19, 218 were males and 144 were females. So the age categories ranged from those patients who were less than 30 years of age to those who were over the age of 80. But largely what we found was that among females, most of those who had been admitted were within the 50 to 59 years category, and among males, most of those admitted were within the 60 to 69 years age category. Overall, though, what we found was that there was a mean age of 58 years among our participants. So we went on further to look at the variety of symptoms that patients presented with and reported to us. Largely, these symptoms were respiratory in nature, followed by constitutional symptoms such as fever, anorexia, and malaise. And thereafter, the next most common set of symptoms were related to the gastrointestinal tract, where patients had complained of diarrhea, nausea, and vomiting. So this data shown here on the slide, just to summarize, shows that among our participants, cough was the most common respiratory symptom and the most common symptom overall, seen among 63% of our patients. Shortness of breath accounted for 58% of symptoms, and fever for 51% of symptoms among our participants. When we go on to look at comorbid illnesses, we recognized that these comorbid illnesses were primarily observed among our male participants. Hypertension and diabetes were the primary comorbidities that were noted for most of our patients, with hypertension seen among 55% of our study population and diabetes among 41%. Of note, cardiovascular disease, obesity, and chronic kidney disease were among the top 5 list of comorbid illnesses. Interestingly, but not shown on this slide, was that 55% of our patients had 1 to 2 comorbid illnesses. When we look at the severity of illness for the participants that we had, patients ranged from asymptomatic to being critically ill. You might wonder why it is that we had to admit patients who were asymptomatic or had mild infection. But you may recall that early during the local outbreak in Jamaica, we were admitting patients of all severity out of an interest for preventing community spread. And as the local outbreak continued, we realized that even when we were in the throes of our first surge, we still had to admit patients with asymptomatic or mild illness because they had another significant non-COVID illness that needed to be treated in hospital. Most of our patients, however, were admitted with moderate or severe disease, accounting for about 51% of our patients, and approximately 11% of patients were critically ill. We looked at the prevalence of certain adverse outcomes, and we were interested in 7 of these adverse outcomes: acute respiratory failure, acute kidney injury, admission to our COVID ICU, and death while admitted to the COVID ward. So acute respiratory failure accounted for an adverse outcome 26% of the time, and acute kidney injury was seen 16% of the time. ICU admission as an outcome occurred 18% of the time, and our inpatient mortality on the COVID ward was 17%. Less common adverse outcomes were sepsis, secondary infections such as secondary bacterial pneumonia, urinary tract infections, bacteremias, and also coagulopathy. So in this multivariable model, we examined the strength of association between the 7 clinical variables, clinical outcomes, which I'd mentioned on the previous slide, and those are shown in the top row in deep blue. And we wanted to see the strength of association between these clinical outcomes with age, sex, and a number of comorbidities. So I will just highlight for you the findings of significance. And what we found when we looked at the development of acute kidney injury among our participants was that among males and patients who had pre-existing diabetes, there was a 3-fold higher odds of developing acute kidney injury in these subgroups. We found also that among patients who had obesity, that there was a 5-fold higher odds of developing acute kidney injury. When we look at the outcome of death, we recognized that there was a 1.03 higher odds of death among participants for every 1 year increase in age, and so advancing age was definitely associated with higher odds of death. And we noticed too that as it pertains to death, that obesity was associated with a 2-fold higher odds of death. So if you look at the last line in this table, you'll realize that obesity is a concerning risk factor for adverse outcomes. In fact, not only is obesity associated with higher odds of death and acute kidney injury, as I'd mentioned, but it is also associated with a 4-fold higher odds of admission to ICU, a 5-fold higher odds of developing respiratory failure and ARDS, and a 3-fold higher odds of developing sepsis while in isolation. So this forest plot here shows that obesity relative to other comorbidities is indeed associated with higher odds of death, even when we adjust for age and gender. And so our study findings have to be looked at in the context of some limitations. So only those patients who were SARS-CoV-2 PCR positive were recruited. So at the time when we had written up our proposal, the PCR test was the main test that we were using for identifying patients as having COVID. And at that time, antigen tests and antibody tests in Jamaica were being still under validation process. So we did not include those patients. Obesity was not objectively assessed in this study. We did not have access to the body mass index of most patients or their waist circumference. And so the finding of obesity was really based on the physician's subjective assessment when they made their documentation after seeing the patients. The excessive mortality of 17% that we identified in our study could be due to the fact that the university hospital during the first year of the global pandemic served as a major referral site for COVID-19 specialist care. And so it is possible that we just attracted patients who were severely affected. I'd mentioned that we had a 17%, an 18% admission to our COVID ICU, and we believe that this is a gross underestimate. Our ICU bed spaces are fixed, and there are many times throughout the first wave that we had to bring ICU care to the patients on the ward, and so quite a number of patients received ICU care outside of the physical ICU space. Remember too that this is a single center study of Jamaican patients, and therefore it might be difficult for us to make great generalizations to the wider Jamaican population. And so in conclusion, I just want to highlight the summary findings of this study of hospitalized patients admitted to the university hospital in that first year of the global pandemic. So we admitted primarily males. 62% of our patients were males. And the mean age overall for our patient population was 58 years of age. The main comorbidities identified were hypertension and diabetes, but cardiovascular disease, obesity, and chronic kidney disease were among the top 5. Patients primarily presented with respiratory symptoms, cough and shortness of breath. However, in terms of constitutional symptoms, I just wanted to point out that fever was reported among 51% of our patients, which makes us question the utility of doing temperature screens at the various checkpoints as we have been doing over the past 18 months or so. Acute kidney injury is a concerning complication, especially among male patients, diabetic patients, and obese patients. Age and obesity we identified in our study as being independent risk factors for excess morbidity and mortality, and our inpatient mortality rate was 17%. And so early identification of high-risk patient subgroups, as we had shown from this study, may facilitate targeted interventions geared at improving outcomes among these patients. So I just want to end by acknowledging the members of our research team. We have a number of researchers from the Faculty of Medical Sciences, and I'll just quickly call their names. Drs. Yvonne Dawkins, Swaney Road Gardner, Lisa Chin-Harty, Ho, Professor Trevor Ferguson, and Dr. Kelvin Akimetalor. I'd also like to express thanks to Mr. Anthony Myers, our data manager, Heather Stewart, our research nurse, and Vanessa Fraser, our project administrator. And of course, I have to express great gratitude to our CDC collaborators for their support during the course of this project, Doctors Kelly and Gordon Johnson and Varo Dede. I thank you. Over to you, Chair.
Thank you, Dr. Thompson, for your well-delivered presentation and highlighting the fact that a person with comorbidity are a person who should have targeted intervention, and maybe that also explains why we also target them with vaccination drive to ensure they have that increased chance of surviving. The next presenter will be presented to us by Zoom is Miss Ashley Boyne, and she is a recent graduate of the University of West Indies, Mona, with a bachelor's degree in psychology. She's currently getting research experience with Professor Audrey Pottinger, a psychologist, in the Department of Child and Adolescent Health in the Faculty of Medical Sciences. At UA, she is now pursuing her PhD degree in psychology, and she also helps in the supervision of other students who are doing research. Today, she's going to present to us a pilot study on pregnant adolescents and adults' reproductive concerns and mental health during the COVID-19 pandemic. Please make her welcome as she presents on this topic.
Good afternoon, everyone. My name is Ashley Boyne, and today I will be presenting on a pilot study conducted by Professor Pottinger and myself, where we looked at pregnant adolescents and adults' reproductive concerns and mental health during the COVID-19 pandemic. I will be covering the introduction and objectives of the study, our methods, results, where I will be highlighting key findings and the conclusions and implications of this study. So studies have documented higher levels of mental health concerns among pregnant women during this current pandemic. However, not much is known about pregnant adolescents, even though psychologically they are more vulnerable to struggling emotionally and mentally during the COVID-19 pandemic. Adolescent mental health has been of concern, with reports of increased anxiety and depression and a lower quality of life due to restrictions, social isolation, and the exhaustion of online school. Additionally, with schools closing, adolescent girls are spending more time with boys and men, which increases the likelihood of risky sexual behavior, sexual exploitation, and adolescent pregnancy. Teenage pregnancy has increased significantly during the pandemic, with one study citing as much as 65% out of sub-Saharan Africa. These pregnant teens are much less likely to return to school. Minimal information exists on the maternal mental health of both adults and adolescents. So with these compounding factors, we, one, wondered whether pregnant adolescents faced more mental health concerns than adults during the pandemic. Two, we sought to compare the lived experiences and mental health concerns of pregnant adolescents and young adults during the COVID-19 pandemic in Jamaica. And three, we sought to examine pregnant adolescents' attitudes to their pregnancy. The methodology we used was secondary analysis of two databases. One consisted of pregnant adolescents between the ages of 14 and 18 enrolled in a national school program for pregnant adolescents organized by the Women's Center of Jamaica. The other consisted of pregnant adults with a mean age of 31 years old, recruited from the offices of OBGYN practitioners in Kingston. Data were collected using a semi-structured interview, and for the purposes of this pilot study, we extracted qualitative data from open-ended questions related to experiences of being pregnant during a pandemic and the impact of the pandemic on the mental health of these women. These individual interviews were conducted starting in July 2020 and ended in March of this year. We applied open coding to extract themes, which were then thoroughly discussed and agreed upon by both investigators. The data were then entered into SPSS for analysis. So for the results, our data showed that 42% of participants, which is 15 in total, were not worried about the threat of COVID-19 on their pregnancy. Of this 15, 12 were adolescents. Additionally, 80% of the adolescent participants reported that the pregnancy actually changed their lives for the better. Some common themes that emerged from participants who were concerned included restricted movement, like not being able to go out or see friends and family, restricted celebrations, like not having the family present at birth or not having events to celebrate the birth of the child, maternal and baby anxiety, where the mother had a fear of contracting the virus and also had concerns about antenatal and perinatal care. And finally, discomfort with COVID-19 protocols. Most of these themes were reported by the adults, but the adolescents mainly had concerns about wearing a mask. These are some quotes by the participants about the concerns they had with their pregnancy. They described feeling sad and annoyed that the father cannot be involved in doctor's visits and how they can't shop for baby and maternity clothes. They also voiced restrictions about baby-related celebrations. One woman said she had to have a small baby shower, and another worried about not being able to christen her baby. The adults also expressed anxiety about their safety and impending care, such as being afraid of doctor's office visits and feeling worried about in comparison, as I said previously, the main concern expressed by adolescents was with mask wearing. Several complained that they had to wear a mask everywhere, and one stated that she had issues breathing through it. Relating to mental health concerns, about a third of the total sample reported not being emotionally affected by COVID-19. One pregnant adult who was already a mother reported that she was okay being at home with her children and that she was adjusting well. Of note, however, 67% were impacted emotionally. Specifically, when we looked at maternal anxiety, 52% of adults described feeling anxious about their health and their baby's health, while none of the adolescents expressed this concern. Some quotes from the women who were concerned about their mental health included one woman describing feeling stressed, especially when others are not as careful, and another saying she was afraid and therefore worried about being positive around delivery time. Only one adolescent explained that she lives in fear of contracting the virus. The adolescents and adults used different vocabulary to describe their mental health concerns, with the adolescents more often verbalizing feeling depressed and sad, as opposed to the adults feeling stressed and on edge. However, in general, More than a third of both groups reported feeling anxious and scared. In conclusion, most of the participants reported some form of mental health concern, with maternal anxiety being a particular concern for the adults. Additionally, the adolescents described positive attitudes towards pregnancy and did not appear to be as concerned as the adults about the impact of the pandemic on their pregnancy. One implication from this study is that research using larger and representative samples needs to be conducted for developing effective protocols for screening mental health concerns of pregnant women by healthcare providers, especially during a global health crisis. A second implication is based on the majority of the adolescents having a positive attitude about being pregnant, as well as not being concerned about their pregnancy during the pandemic. Further research is needed to explore if this apparent indifference to their pregnancy is common among Jamaican adolescents and the reason behind this attitude. Such information could help with planning sexual education programs for our schools with the intent to prevent adolescent pregnancy. I thank you all for listening and for your attention.
Thank you, Ms. Boyne, for your presentation with interesting findings that the adolescents seem to be dealing well in terms of mental health during pregnancy as opposed to the adults. I'd be very interested to know what's the underlying reason for that. It may be very instructive. And also, thank you for that point about screening, for pregnant person to be screened, because we know the increased risk of depression during person being pregnant. I should point out earlier that we'll entertain questions and answers at the end of all the presentations. So please make a notation of your questions. You can put it in the chat, or you can say your questions live when we give the time for you to do that. Our next presenter is Dr. Roxanne Melbourne Chambers. She is Senior Lecturer in the Department of Child and Adolescent Health at university, and she's Program Director of Doctor of Medicine in Pediatrics, and she's also the head of the Department of Child and Adolescent Health. Of note, her main research interests are in epilepsy in Jamaican children, the epidemiology, cognition and quality of life, and the neurological complications of arboviral infections in Jamaican children. She has many related publications, which include the clinical effects of chikungunya in Jamaican children, congenital Zika syndrome in Jamaican children, and the demyelinating diseases associated with Zika and dengue in Jamaican children. So she's well suited to present to us the neurodevelopmental outcomes of congenital Zika syndrome in Jamaican children. Please make her welcome.
Good morning, colleagues and friends. Just want to clarify, am I sharing my slides?
No.
Am I required to share my slides? Or?
Yes, please do. Just go ahead and share your slides.
Give me a second, please.
Yes, you can go ahead and share your slides now.
Okay, 1 second, please.
Okay.
Are you able to see? Are you seeing the slides?
No, I'm not seeing it yet.
Are you now able to see?
Yes, we're able to see now.
Thank
Perfect.
you. Good afternoon, moderator, colleagues, and friends.
Good afternoon.
Thank you for allowing me to present at this conference. And I'm presenting the findings of a retrospective study done by colleagues at the University Hospital of the West Indies, Spanish Town Hospital, the Victoria Jubilee Hospital, and the Bustamante Hospital for Children, as well as collaborators in Argentina and in the UK, part of the Zika Action Pediatric Study Group. So here we're looking at the neurodevelopmental outcomes of congenital Zika syndrome in Jamaican children. By way of background, we remember that the Zika virus, which is a flavivirus of the family Flaviviridae, was isolated in non-human primates in Uganda in 1947 and in humans in Nigeria in 1954. But it was not until another 60 years that the first recorded outbreak was noted in the Micronesia Islands in 2007. And then following that, there were epidemics in French Polynesia in 2013 and 14, and in Brazil in 2015. And we'll recall that Jamaica recorded its first case in January 2016. We do know that most individuals infected with the Zika virus are asymptomatic or have mild illness, but also that the disease has been linked to severe neurologic manifestations, both in children and adults, and these include the Guillain-Barré syndrome. In September 2015, increased numbers of newborn infants with microcephaly were being observed in ZIKV affected areas of Brazil. And after that, retrospective studies were done from French Polynesia, which also noted that there were increased numbers of instances of microcephaly and other fetal abnormalities after the 2013 to 2014 outbreak there. And these associations then prompted the World Health Organization to declare a public health emergency of international concern from February to November 2016. Vertical transmission with Zika has been associated with congenital Zika syndrome, which describes or relates to a severe microcephaly with a partially collapsed skull due to the fetal brain disruption syndrome. There's craniofacial disproportion, microphthalmia, cataracts, macular atrophy, severe arthrogryposis, intrauterine growth retardation, and sensorineural hearing loss. And the neuroimaging findings of this congenital Zika syndrome most commonly show calcifications at the cortical-subcortical junction, developmental malformations of the cerebral cortex, ventricular megaly, and abnormalities of the corpus callosum. And so these two pictures are showing the severe microcephaly with that collapsed skull and the rugae, the scalp rugae in the top picture, and that MRI, sagittal MRI of the brain showing a very small head related to the face, and the arrows are pointing to the very hypoplastic corpus callosum. This is important because in addition to the increased demand for healthcare services and social support, mothers of children with congenital Zika also report problems like social inequality, poverty, and gender inequality, their maternal isolation, anxiety, depression, stigma, and prejudice, and exhausting itineraries searching for therapeutic care. In December 2015, the Ministry of Health Jamaica required the reporting of microcephaly in newborns and pregnant women who fit the surveillance case definition for ZIKV infection. And this included rash or elevated body temperature more than 37.2 Celsius, with one or more of the following symptoms not explained by other medical conditions. And these included arthralgia or myalgia, non-purulent conjunctivitis or conjunctival hyperemia, headache or malaise in someone who resides in or has visited epidemic or endemic areas within 2 weeks prior to the onset of symptoms. And then by May 2016, rash only was added to the case definition among pregnant women. By late 2016, cases of newborns with microcephaly and arthrogryposis were being recognized in Jamaican hospitals. And this led to a publication by our collaborator, Dr. James Powell and team, noting these findings at hospitals in the Kingston metropolitan region. In June 2016, the European Commission funded 3 consortia, including ZIK Action, to perform collaborative population-based research to better characterize the epidemic in Latin America, the Caribbean, Europe, and other sites. And the pediatric registry is one of these research activities. It's a multi-center registry of infants and children with documented ZIKV exposure in utero and or with confirmed or suspected congenital ZIKV infection. Activities were conducted from August 2020 onwards, and overall 187 children have been enrolled. The UWI is the center in Jamaica, which has 55 participants. In Brazil, Fiocruz Bahia, 129 participants, and 3 participants from Argentina. And this study looks at retrospective collection of data on socio-demographic characteristics, maternal, pregnancy, and delivery data, newborn and pediatric assessments, physical, neurologic, developmental, ophthalmologic, audiological, and lab results. There's some prospective data available from the Brazil site about follow-up assessments, and the data were pseudo-anonymized and entered into a REDCap database, and it's planned that pooled analyses will be conducted to address questions relating to characteristics, health, and neurodevelopmental outcomes of this population. As part of a multi-center registry, therefore, this study aimed to characterize the clinical, radiological, neurodevelopmental, and laboratory features of children antenatally exposed to ZIKV and or who presented with suspected congenital Zika syndrome in Jamaica. This retrospective study of children included those potentially exposed to Zika antenatally and who attended clinics or were admitted to the Spanish Town Hospital, the Victoria Jubilee Maternity Hospital, Bustamante Hospital for Children, or University Hospital of the West Indies. The inclusion criteria, there had to be one or more of the following: microcephaly at birth, features of congenital Zika syndrome or exposure to Zika in utero, and data on maternal demography, antenatal labor delivery history, newborn anthropometry, results of hearing, vision screening, neurodevelopmental assessments, laboratory radiological investigations were all extracted from hospital records. And descriptive and chi-square analyses were performed, and ethical approval was obtained from the Southeastern region, the Ministry of Health, and the respective hospitals. So our results. We had 55 participants, and 60%, 61.8% of them were female. As we can see, the majority of cases who were enrolled were born in the years 2016, 26 of them, and 2017, 24 of them, with a few, very few, born in 2018 and 19. In terms of the maternal characteristics, these were young women with a mean age of 27.4 years, 12 or 21.8% were Zika symptomatic, but only 3 or 5.4% had a laboratory diagnosis of Zika. The most common symptom of Zika was a rash in 18.9% of them. And these were healthy women. Only 4 or 7.5% had hypertension, 2 or 3.6% with sickle cell disease, and only 1 participant admitted or reported maternal smoking. Of the neonates, these were term neonates with a mean gestational age of 38.4 weeks, and only 4 or 7.3% were premature. They came out with relatively good APGAR scores at birth. So the mean APGAR score at 1 minute was 8, and at 5 minutes was 9, and only 4 or 7.3% had a low 5-minute APGAR score. Their birth weight and length were normals, with a mean birth weight of 2.7 and a mean length of 47.3, but the mean head circumference or occipital-frontal circumference was 30.9 centimeters. 9 or 16.4% had low birth weight, and only 1 child went on to, we were only able to get results for 1 child who was Zika positive, and that's 1.8%. In terms of congenital abnormalities, 31 or 56.4% of participants were microcephalic, and 20 or 37% showed features of craniofacial disproportion. The other features that were present included biparietal depression in 20%, a prominent occiput in 16.7%, and excessive nuchal skin and scalp skin in 13 and 7.4% respectively. Apart from these features of congenital Zika syndrome, the more common other congenital abnormalities described included eyes and ENT dysmorphisms in 33%, and arthrogryposis in 5.5%, with other abnormalities of the hands and feet in 10.9%. And this is a picture of one of our participants who has the microcephaly, the arthrogryposis. In terms of head circumference categories, 25% of the group had severe microcephaly, and 30.9% had mild to moderate microcephaly. 40% had normal head circumferences. 29 children were able to have neuroimaging studies, and of those studies, the most common finding in 8 or 33% was enlargement of the ventricles, ventricular megaly. Cerebral and basal ganglia calcifications were noted in 29.2%, and migrational abnormalities and cortical atrophy in 20.8% respectively. Cerebellum malformations were also found in 12.5%. In terms of outcomes, we have information on development in 36 participants, and 55% of those had developmental delay. Of 34 participants who had ophthalmology examination, 26.5% had an abnormal eye exam. Of 12 who had a hearing evaluation, 50% had abnormal hearing, and 50 who were inquired of seizures, 12% of those had seizures. NICU admissions were very common among this population in 66%, and mainly for their congenital abnormalities, but also for findings of respiratory distress, seizures, and prematurity. In this group, there's one death accounting for 1.8%. So we found that developmental delay in the child with CSAS, congenital Zika syndrome, was frequent, occurring in 55%, and was associated with abnormal neuroimaging, eye abnormalities, and hearing abnormalities, but there was no significant association with either head circumference, birth weight, or gender. In this population, congenital Zika syndrome was more common in females. Approximately half developed developmental delay associated with abnormal neuroimaging, eye findings, and hearing loss. And these findings, we feel, are similar to other published reports of congenital Zika syndrome and underscore the need for early intervention services and social support for affected children and their families. The limitations in this study were, one, the unavailability of laboratory results for Zika virus and torch infections in this population, and the limited follow-up of some patients. And we feel that this patient population was particularly affected by stigma, and many of those families, just did not want to come out to the hospitals for follow-up and continued care. I'd just like to share with you now a very short video on the Zika Action project and its impact.
Zika is a virus that spreads through infected mosquito bites. If a pregnant woman is infected, her baby also risks infection. My health was in danger. In 2016, Penta started Zika Action, a research project to study Zika's impact on pregnant women and children. Funded by the European Union, Zika Action was a collaborative effort, uniting doctors and researchers across Europe and Latin America, where the virus hit hardest. Researchers now have better tools that could be used not just for Zika, but also for future epidemics. We are a big step closer to finding new treatments and vaccines. Zika Action cast a light on me, my mum, and all babies whose lives were at risk, so that no one is left behind.
And I'd like to just end by acknowledging the tremendous contribution of our pediatricians, nurses, and medical record staff at the 4 hospitals, our Zika Action collaborators in the UK and in Latin America, the Penta Foundation and the European Union that funded this research, and Mrs. Ashley Bingham, research assistant, who was very helpful to us in gathering the data. And last but not least, we acknowledge the families and children affected by Zika for allowing us this opportunity to review the data. Thank you.
Thank you, Dr. Melbourne Chambers, for giving us information about congenital Zika syndrome, and in fact we need to have early intervention, and also the social impact that it have on the families, not only mothers, but the families from which these children are coming from. And hopefully we'll be seeing the back of Zika. We won't see any more Zika in the future. Now we're going to the 4th presenter, who is Miss Kimberly Mackenzie. She's a PhD pharmacology student. Her research is focused on response of the anticoagulant warfarin, where she has done both clinical and animal studies, investigating different factors that may influence the response to warfarin. She currently delivers lectures in various areas of pharmacology to undergraduate students and co-supervises undergraduate students with their final year research projects. So she's going to present to us now gender abdominal adiposity dimorphism of warfarin response in rats fed a vitamin K deficient diet. Please make welcome Ms. Mackenzie.
afternoon, everyone.
Good afternoon. You can go ahead and share slides.
I'm trying to share.
Okay.
Okay, so good afternoon, everyone, again.
Good afternoon.
So I'm Kimberly Mackenzie, and I'll be presenting on gender abdominal adiposity dimorphism of warfarin response in rats fed a vitamin K deficient diet. Co-investigators of this study are Dr. Jacqueline Campbell and Professor Maxine Gossel-Williams. I'm sorry, my slides aren't changing. Okay, yes. So this is the outline of my presentation. So I'll start with the introduction and then conclude with references. So warfarin is the most widely used oral anticoagulant agent. It prevents thrombotic events such as conditions such as cardiac valvular disease, atrial fibrillation, venous thrombosis, and it prevents these events by preventing blood coagulation by inhibiting the synthesis of vitamin K dependent clotting factors. So it does this by competitively inhibiting the enzyme vitamin K epoxide reductase and therefore preventing the oxidized form of vitamin K from being converted to the reduced active form, which is known as vitamin K hydroquinone, which is a cofactor for the synthesis of clotting factors 2, 7, 9, and 10. So the therapeutic response of warfarin varies highly among individuals, and factors such as weight, body mass index, and adiposity have been reported to influence the therapeutic anticoagulation and initial response to warfarin. Vitamin K is a fat-soluble vitamin, and it is found naturally in two forms, vitamin K1 and vitamin K2. Vitamin K1 is mainly found in plants, while vitamin K2 can be found in meat, dairy foods, fermented soybeans, and are known to be synthesized by bacteria in the GIT. Vitamin K has been reported to be stored in various sites within the body. Such sites include liver, adipose tissue, pancreas, brain, and the heart. So vitamin K has been reported to be in greater concentrations in adipose tissue compared to vitamin K concentration in circulation. Reports have been made of lower vitamin K concentration in tissues of mice fed a vitamin K deficient diet food for 28 days versus control animals that were fed normal supplemented vitamin K diet. The prothrombin time is a clot-based test that is used to measure the integrity of the extrinsic and common pathways of the coagulation cascade. And its normal range is between 11 to 15 seconds. Vitamin K deficient diet has been reported to prolong prothrombin time in Sprague-Dawley rats with males having a faster onset. Anticoagulation with warfarin therapy has been suggested to be influenced by adiposity in human studies. Female rats have been reported to be more resistant to anticoagulation with warfarin during vitamin K deficiency. So therefore, we hypothesize that with greater abdominal adiposity, there will be a slower anticoagulant response to warfarin. And the objective of this study is to determine the relationship between abdominal adiposity and the warfarin anticoagulation response in male and female sprug dolly rats whilst being fed vitamin K deficient diet. So this study was, ethical approval for this study was sought and granted by the University of the West Indies Ethics Committee. So for the animals that were used to carry out this study, a total of 48 animals, equal numbers of males and females, approximately 5 to 7 weeks old, were selected for this study. They were divided into 2 equal groups, where one group was fed a high-fat diet, while the other a standard chow diet for 10 weeks, followed by a diet, a vitamin K supplemented diet for approximately 4 weeks. Following this period, the animals were then initiated with warfarin dosing, while being fed a vitamin K deficient diet for 6 days. So prothrombin time was measured before warfarin dosing on day 0 and 2 and 6 days after initiation of warfarin dosing. 14 days after the initiation of warfarin dosing, the animals were fasted overnight, where they were euthanized, and adipose tissue was collected, dissected, and weighed for analysis. So for the animals that were dosed with warfarin, the dosing of warfarin are equivalent to human dosing of warfarin, so 0.07 milligrams of warfarin per kilogram is equivalent to 5 milligrams warfarin per 70 kg in humans, and 0.035 milligrams warfarin per kilogram that was given to the rats is equivalent to 2.5 milligrams warfarin per 70 kg body weight in humans. So the prothrombin time of the rats was measured by the Kogu Check XS system. It's a point-of-care device that measures prothrombin time and has been used and validated in previous studies to measure prothrombin time in rats. Data was analyzed using the SPSS statistical software package, version 20. Parametric data was represented as mean plus or minus standard deviation, and non-parametric skew data was represented as median interquartile range. ANOVA and repeated measures with 2 key post hoc tests was used to analyze the parametric data, while Mann-Whitney U and Spearman's correlation tests were used to analyze non-parametric data. So for results, so this figure shows the body mass index of the rats over a period of 10 weeks, where the high-fat diet males had a higher body mass index, followed by high-fat diet female, and then standard chow diet male, and then standard chow diet females. So this figure shows the prothrombin time of rats over the 6 days period, where figures A and B are showing animals that received a lower dose of warfarin, while figures C and D is showing the results of animals that got the higher dose of warfarin, which is 5.0 milligrams per 70 kg. Okay, so for the males that receive both doses of warfarin, over time, over the 6 days period, there was a significant increase in their prothrombin time, between the groups for both doses, between the male groups for both doses of warfarin, the high-fat diet males had a significantly higher prothrombin time than the standard chow diet males. So this figure is showing the abdominal adiposity index of each group of animals, where the high-fat diet females had significantly more adipose tissue than the standard chow diet females. And for both diets, high-fat and standard diet, the females had significantly more abdominal adipose tissue than the male groups. So Spearman's correlation has shown where abdominal adiposity index is positively correlated with gender and negatively correlated with the initial prothrombin time, that's prothrombin time without warfarin administration, as well as prothrombin time 2 days and 6 days post warfarin administration. So for discussion, male rats gain more and higher BMI than female rats of the same age, whether on normal or high-fat diet, and this is similar to other studies. And male rats of both dietary groups were more sensitive to warfarin response when being fed a vitamin K deficient diet. And hormonal differences has been suggested to promote a female gaining more subcutaneous adipose tissue, while male rats gain more visceral adipose tissue in high-fat diet feeding, which has been suggested to have different roles in hypercoagulability. For conclusion, with greater abdominal adiposity, reduces the anticoagulation response of warfarin during a low vitamin K intake from diet, and gender dimorphism are apparent in this response. Female rats gain significantly more white abdominal adipose tissue, including when fed high-fat diet, and therefore are less sensitive to anticoagulant effects of warfarin, and male rats were more resistant to abdominal adiposity increase with high-fat diet feeding and are more sensitive to warfarin anticoagulant response. So this study is limited by the lack of vitamin K concentration analysis in tissues, as well as the lack of adiposity biomarkers. So I'd like to thank God for his continued guidance throughout this study, my supervisors, the Office of Graduate Studies for their continued support, the Department of Basic Medical Sciences, the pharmacology technical staff, and my fellow student colleagues. Thank you.
Thank you, Ms. McKenzie, for walking us through that research, animal studies, and I'm sure it will have implications for human, which I'm sure you'll let us know at some later point in time. At this point in time, now we'll ask if there are any questions from persons on Zoom land or persons in the room for any of the presenters. Please pose your questions now.
Dr. Tamara Thompson. Again, thanks for your presentation. So the clinical features and outcomes were for patients that university would have seen in the first year of the outbreak, when we had a particular strain of the COVID virus. Do you project that the clinical outcomes are now different given the various strains that we're seeing? And is there a plan by your group to continue to look at the clinical outcomes and compare across the different strains that we're seeing? Thank you.
Okay, thank you for that set of questions. So yes, the study was conducted when we had the ancestral strain and the UK variant circulating in Jamaica. We have continued to collect data, and we have collected data up until perhaps last week. So we do have some data that we will have to work through so that we can continue to look at the outcomes. It's going to be interesting to see if the outcomes remain the same, but time will tell once we work through the data.
Thank you for that question. Thank you for that response.
Dr. Lunge.
Thank you. The follow-up question on that is, do you have the individuals coming in, or you're doing a general population testing, or is it those that come to you because they have symptoms that you're going to be testing for this group?
I'm not sure I'm understanding the question.
For the variants, okay?
Mm-hmm.
For the variant, for the research, for the group, you're collecting this. I'm asking, is it that you have persons who come to the hospital, or those who, you understand, is it a general testing, or is those who have? Yeah.
Right, so the studies that we conducted at the university is really those patients admitted to our isolation ward, so it's a UHWI study.
Okay, so there are indications that there might be individuals we will not be able to pick up in the population because they didn't have symptoms to bring them to the hospital.
Right, so our patient population includes those patients admitted to the wards directly from the emergency room or transferred to our hospital because they needed specialist care. So that's the smaller sample that we're dealing with.
Thank you.
Thank you for that question and that response. And then more questions?
Okay, to our last presenter, Ms. Melbourne Chambers, was it? Kimberly, right. McKenzie. Okay, thanks for your presentation as well. So your study is currently the animal based. What are your projections and how will this impact human health? What are you hoping to achieve in extrapolating this information to the management of health conditions? What are you planning for the future regarding the information you're collecting via your studies?
Okay, thanks for that question. So for this part of the study, we are trying to see how these factors may affect warfarin response, and therefore have this information to see how this can help with the monitoring of the patients that are on warfarin, and to see how better to treat those patients, and to even understand better why we have so much variabilities among the patients that are on warfarin.
Okay, thank you, thank you. Here's a follow-up question.
Mm-hmm. Okay, thank you. I have a question for Dr. Chambers. Can I go on?
Yes, go ahead.
Okay, Dr. Chambers, thank you for your presentation. I was wondering, for the Zika syndrome in Jamaican children, are we still looking about this study? Are we still checking for individuals who have children at this time? Is it a forward research where this group will continue to look out for, or we're just looking at the time when Zika was like an epidemic? So that's a question for Dr. Chambers.
Thank you for that question. Regarding the research, unfortunately for the Jamaica site, the study is retrospective at this time, because when approvals were obtained, it was in the height of the pandemic, and that limited our ability to get to the families and for the families to come in. And so we had to move on with our retrospective study. However, having had the Zika experience, the practice amongst persons managing moms and babies who are born to moms who may have congenital abnormalities or microcephaly is that Zika is now, like torch infections, routinely ordered as an investigation. But with regards to the research study, it was retrospective.
Okay. All right. Thank you.
Yes, thank you for that question and the response from Dr. Chambers.
Okay, this question is to Ms. Boyne Ashley, that looked at the pilot study on pregnant adolescents and adults. Based on the results that are coming out from your pilot study, what are some of the things you would suggest to the Ministry of Health that we would want to focus on as it relates to mental health for this group, or public health education in addressing some of the issues that's affecting this group coming out of the COVID pandemic?
Thank you for your question. We did find that a dominant mental health concern for both the adolescents and the adults was anxiety. So that could be a major focus for the ministry to screen for with pregnant women. But since this was a pilot study, we wanted to do further research on their mental health concerns.
Thank you.
Thank you, Ms. Boyne. Thank you for that question. Ms. Shirley Jones. Any more questions? Okay, since there are no more questions, it is me just to, again, commend and congratulate the presenters for this session, Dr. Tamara Thompson, Ms. Ashley Boyne, Dr. Roxanne Melbourne Chambers, and Ms. Mackenzie for their high-level presentation of research done and the findings and the discussion we had concerning those studies. So thank you again, presenters, and this is the end of this session. Please stay tuned for the next session.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're not wearing a mask, you're not washing your hand, and you're not keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah. It not gone nowhere. COVID-19, they are same way. So here why you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Dion Jax-Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers,
frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older like me and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vaccine 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop for it because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop for it.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Booking your COVID-19 vaccination appointment is simple. Use one of 2 options. Option 1. Register using the online portal at the Ministry of Health and Wellness's website. Go to www.moh.gov.jm, click Apply here for COVID-19 vaccinations, and follow the instructions on screen. Enter your mobile phone number. You will receive a text message with a one-time password. Enter it on the site to confirm your account. Fill in the information requested. Choose your parish and a vaccination center there. Then schedule a date and time convenient to you. You will receive a text confirmation with the details of your appointment. Option 2. You may also book your vaccination appointment via telephone. Call the National Vaccination Center at 888-1-LOVE. That's 888-663-5683. A representative will take your information, book you at the nearest vaccination site, and register your appointment. You now have a vaccination appointment. For your first dose, When going to the site, take your TRN and a government-issued identification or letter from a justice of the peace. For your second dose, take to the appointment your vaccination card, TRN and a government-issued identification or letter from a justice of the peace. You may ask a relative or friend to help you book your vaccination appointment. Book your COVID-19 vaccination appointment today. Get vaccinated. Get back to life.
Some of we have all sorts of excuse as to why we don't want to wear the mask. The place too hot. We're not used to it. It's not comfortable. Look, you know. Wake up and smell the country chocolate. Them excuse, they're not going to make it. You may know the place hot. But you don't want to feel COVID-19 fire in your lungs. And used to. The only way to get used to a thing is with practice. So practice and wear your mask. And as for the start now about comfortable, not no more comfortable than being COVID-19 free. So find a mask with fit.
COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
From worry over your finances to mask wearing and physical distancing from your family and friends, your concerns about COVID-19 may be many, but you can overcome. Take care of your mental health. Keep a journal. Talk about how you're feeling with someone you trust. Exercise. And yes, take the time to smile.
Hello? Hello? Yeah, you. Hold on, and a pandemic winner. You're not wearing a mask, you're not washing your hand, and you're not keep the required 6 feet distancing from other people. And what could that really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah, it not gone nowhere. COVID-19, they are same way. So here why you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular. And yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Miller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently, and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects, and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older, like me, and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vax in 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica. That was a message from the Ministry of Health and Wellness.
COVID has stressed me. Do take the vaccine.
And through it all, our healthcare workers have been the real MVPs tackling COVID-19. Caring for you is our priority. As frontliners in the pandemic, they got vaccinated.
I got the vax. I had to protect myself so that I can protect you. No, sir?
Me, stop fret because my vax up.
I made sure my mom and I got the vaccine. Protection is key.
Me, vax up, me stop fret.
Fam, help us protect you,
your family and friends.
So should you.
Enough now. Take the vaccine.
Get vaccinated. Get back to life.
Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the elderly. Don't you want to go back to living normally when things were more orderly? And if you want to live a long good life, then we all have to do what's right. So let's get vaccinated along with the heroes on the front line.
A message from the Ministry of Health and Wellness.
Booking your COVID-19 vaccination appointment is simple. Use one of 2 options. Option 1. Register using the online portal at the Ministry of Health and Wellness's website. Go to www.moh.gov.jm, click Apply Here for COVID-19 vaccinations, and follow the instructions on screen. Enter your mobile phone number. You will receive a text message with a one-time password. Enter it on the site to confirm your account. Fill in the information requested. Choose your parish and a vaccination center there. Then schedule a date and time convenient to you. You will receive a text confirmation with the details of your appointment. Option 2. You may also book your vaccination appointment via telephone. Call the National Vaccination Center at 888-1-LOVE. That's 888-663-5683. A representative will take your information, book you at the nearest vaccination site, and register your appointment. You now have a vaccination appointment. For your first dose, when going to the site, take your TRN and a government-issued identification or letter from a Justice of the Peace. For your second dose, take to the appointment your vaccination card, TRN, and a government-issued identification or letter from a Justice of the Peace. You may ask a relative or friend to help you book your vaccination appointment. Book your COVID-19 vaccination appointment today. Get vaccinated. Get back to life.
Some of we have all sorts of excuse as to why we don't want to wear the mask. The place too hot. We're not used to it. It's not comfortable. Look, you know. Wake up and smell the country chocolate. Them excuse, they're not going to make it. You may know the place hot. But you don't want to feel COVID-19 fire in your lungs. And used to. The only way to get used to a thing is with practice. So practice and wear your mask. And as for the start now about comfortable, not no more comfortable than being COVID-19 free. So find a mask with fit.
COVID-19 is still here. Always wear your mask correctly while in public places, covering your nose and mouth at all times. Masks should never be worn over the head, under your chin, below your nose, or hanging from your ears. Recovery from COVID-19 can take up to 60 days or more. The mask or the ventilator? You choose. A message from the Ministry of Health and Wellness.
From worry over your finances to mask wearing and physical distancing from your family and friends, your concerns about COVID-19 may be many, but you can overcome. Take care of your mental health. Keep a journal. Talk about how you're feeling with someone you trust. Exercise. And yes, take the time to smile.
Presenting the topic. Professor Denise Eldemar-Shearer is a professor of public health and aging at the University of the West Indies, Mona, and is the director of Mona Aging and Wellness Center at UWI. Professor Eldemar-Shearer has been a member of the National Council for Senior Citizens, the government's advisory body on the elderly, since 1982. Her work involves developing and implementing policies and programs for seniors in Jamaica to promote their continued participation in all aspects of family, community, and national life. Let us welcome Professor Eldemar-Shearer.
To the health research team for this opportunity to present on the COVID-19 pandemic and the elderly. So as I go through this presentation, and I'm cognizant of the time that we probably need to make up, I'm going to look at national perspectives, and I want upfront to thank Dr. Webster Carr and other members of the team that have provided me with data and information throughout the pandemic to ensure that we are helping to meet the needs of older people. I will look at how COVID-19 has impacted older persons and what effect it has had on them. Older persons were identified very early in the pandemic, even before we in Jamaica were taking it to and putting measures in place as an at-risk groups because of the increased mortality which was seen starting in nursing homes, but then across all the different cohorts. When I say cohorts, I mean countries, sorry. Right from the beginning, comorbidities were identified, particularly blood pressure, diabetes, and obesity. And we heard in one of the earlier presentations the importance of obesity in contributing to morbidity, mortality. But for older people, one of the things that contributes to this increased morbidity, mortality is the declining immune system, where because of the aging process and the interaction with the comorbidities, the body is not able to fight disease as efficiently as in a younger person. WHO reported early, and the CDC, that the things that we needed to take into consideration were cardiovascular disease, diabetes, chronic respiratory distress and disease, and hypertension. In our situation, the data that has come forward on the deaths from Dr. Webster Carr's unit, and she can comment in the discussion, is hypertension. With 68% of the Jamaican population over 60 having hypertension, that gave us some real concern in discussions. So we come to March 2020, which has been referred to by most of the speakers. And right at the beginning, Jamaica placed emphasis on the 60 plus, which was important because it was recognition of the need to prevent increased disability, mortality, morbidity in this age group. And it is something we will see later was actually appreciated by the age group. So the stay-at-home order was put on very early, and therefore for some of our older people, they have now been at home for 18 months. And then added to that was the need to stay with the general precautions. So locally, what have we been seeing? This is the waves, and you will see that it started with a 15.7% cases, went up to 20, and in this third wave is beginning to come down, and I will speak to vaccinations. But we saw also that the this is the deaths. We saw just what everybody else had been reporting, that there was an increased death rate among older people. And we saw it increasing by age, not surprisingly. But you saw the considerable jump just between the 50 to 59 and the 60 to 69. And by the time you come down to the over 90 group, it was up to 32.6% that of case fatality. So we knew early that yes, older people were at risk of death. It's coming down a little bit, as you will see in the next slide, but we are still seeing interestingly, the 60 to 69 has not yet fallen from this, but we are seeing a drop in the deaths in the older. Let me go to the next one. This one. So you will see, for example, we didn't report, or it wasn't reported on the 80 to 89 until January of this year. Prior to that, it was just 80 plus and 90 this. So we've seen where this has dropped from 18 to 14.4 and a good drop in the 90 and over, 32.6 to 18.7. So you will see that. And we see it also when you look at the deaths in the wave period, where 71%, 77.2 to 68.8%. So it is falling. And what is different here is vaccines. So what then was the impact? Because we had this concern of increased illness, but we also had concerns about the impact of stay at home. And it would have been mentioned in one of the other presentations about anxiety that was found in adults, women, and then children, adolescents, and then pregnant women. So the same thing is of consideration dealing with older people. Perhaps what's different is that older people go through social changes such as retirement, loss of loved ones, loss of financial independence, and they experience excessive worry even without COVID, and they do experience loneliness without the stay-at-home order. So you are superimposing on older people, yes, in an effort to protect them, which, as I said, they appreciate and understand, but you are also getting things to confound their worry. COVID-19 came out of the blue for most people without time to prepare mentally. The ministry had time to prepare 3 or 4 months. I suspect they would tell you they would have liked more time. And the immediate threat is now. This threat in March of 2020, I think most people thought, okay, this will be a couple of months and it will be gone, but it's not. It hasn't gone and it doesn't appear to be leaving us rapidly. So there's a prolonged level of concern. Coupled with that is the issues around the variants, and especially when we brought the vaccine started, the whole discussion about was a vaccine effective against Delta or not. And there are many unknowns. Why do we have families? And we have many families that one member of the family, a husband gets it, the wife doesn't get it, vice versa. So there's so many unknowns about it. So you are adding to the concerns of older people. There's the uncertainty that I've mentioned, but most importantly for older people, there's a loss of routine. The older that we get is the more we become creatures of habit. And this habit and routine that we have all gotten accustomed to, especially after retirement, has been disrupted. There's a colliding of worlds. There's the world of illness with the world of wellness. And right now, there's no end date. We can't say to people who are concerned when is life going to become normal. And in fact, everybody now talks about the new normal with an expectation that we're not going back where we're coming from. So Mona Aging and Wellness with our team has been looking at this throughout. So we've tried to combine our research with our advocacy and policy. So in mid-2020, we looked at the findings, what was the impact on older people. 83% had at least one chronic disease. Most people were concerned about COVID. 71 very concerned, 26 somewhat. 98% reported that they were following the guidelines. And most believed that the restrictions and guidelines were necessary. So we did not get the resistance here that we got in some countries where older people said stay-at-home orders were an infringement of their rights, etc. However, 20% of them, and these were usually in the 60 to 70 age group, were usually the self-employed, whether by selling or caregiving. They did report that it was very difficult to follow these restrictions and weren't sure how long they could. Now, when we're talking about stay at home, we were interested in how many lived alone and how were they going to meet their needs. So 20% lived alone, and another 20% lived only with spouses, which meant we had a 40% group of people who were not able to meet their needs by themselves. They reported leaving home less and less family visits, phone being the main source of contact. Interestingly, 24% reported reduced physical contact. And I interacted with a lady about 3 weeks ago. And I asked her, she's fully vaccinated, her son is fully vaccinated. And I said to her, what's the biggest problem? She says, I just would like my son to hug me. He had been visiting her for the 18 months. He went every day. He had not hugged her. She had not had a hug in 18 months. And I said to them right there in my office, they both had on their masks. I said to them, you're both vaccinated. How about at least some physical contact? 34% of these older people did report lack of companionship, isolation, and loneliness. If you take a look at interactions, you don't always speak most conversation sharing with the person that you live with. And one older person said to me, living with somebody does not mean you have friendship and companionship. And these are some of the interesting things that we have seen as we're going along. Most use public transport, and there's a presentation from Dr. Webster Carr about 2 weeks ago that pointed out people are 3.5 times more likely to get COVID in public transport. 64% used the public facilities, and you see here that ability to support was reduced, family support was reduced, and diet. Remember I said 68% had, and in this study, 82% had a chronic disease. Therefore, diet, meeting the needs of hypertension, meeting the needs of diabetes were all of concerns. Significant, 60% had not sought health care. We were told that some did not go, whereas others had their appointments canceled. And you will see later, older people are not doing very well with telemedicine. And as one lady also said to me, how did they measure my blood pressure via the telephone? So we had a lot of missed follow-up appointments, missed eye and dental, and missed hospital appointments. But like everything else, there's always a positive side. And we actually saw less flu and pneumonia in older people last December from the ministry statistics. Fast forward to this year and to June to September of this year. And this study was done by Dr. Ashby Mitchell, Mona Aging and Wellness. So almost 30% are sad that the routine has had to change. So while they were accepting last year and still accepting this year, there is sadness about it. They thought it was going to be for a couple of months, and clearly it isn't. 40% limiting engagement. This has been added to because, of course, they can't go to church, one of the main activities, and they're restricted from family by the stay-at-home order where the family is not immediate. 40% of them are worried about other people and people not, they really get uptight about masks. They say some of the masks being worn in public are not clean and they wonder what use they are. And 40% understand the need, as I said. Now remember, that was 80% in the earlier study. They really want normalcy. The study went on to look at how had it actually affected activities engaged in, and 80% were engaged in activities before, and this had dropped to 68.1%. But they said they weren't the same because of the strict protocols. Yet, new activities, some identified, especially some of our more active older people, that they had developed new activities, the gardening, some physical activity, but most not. And we've seen a lot of muscle mass loss and frailty. Watching sarcopenia in the over 80. Too many of them sitting watching TV and just sitting doing nothing in terms of physical activity, but listening to music, sewing, crafting. So we've also seen efforts to stay involved. We weren't alone. Jamaica definitely is not unique. And there's a recent publication on a rapid review of 6 online databases. And there were reports of multiple barriers to care delivery everywhere, treatment delays and postponed appointments. In the G20 countries, there was 53% disruption in hypertension treatment, 49% in diabetes. And this slide gives an overview of the different countries. The US is 37, Norway, Sweden, Australia. So we're not alone. That's not any reason to take comfort, but just, you know, so that we know it's worldwide. So we'll get some suggestions. And this is, can't read, sorry. This is another set of countries. These were persons who needed help with their activities of daily living, highlighting the, and we found this as well, the importance of caregiving and getting support with caregivers. So in Canada, 31%, for example, did not have their regular caregivers. The ILC reports an estimated increase over the next 5 years of increases in cancer deaths due to delays in diagnosis. And this is something that we will have to monitor here and to watch because they've not been doing the follow-up. There were positives. Older people are definitely more resilient and better able to cope with stressful events. And in that database study, it showed that older people actually had less depression, more anxiety, but less depression than younger people. Cognitive impairment, and I'm not saying dementia yet, I'm saying cognitive impairment warrants some consideration. We have seen signs that there is some increased memory loss. Whether it is that because people are interacting more, they are actually picking it up and noticing it, or is it the lack of social stimulation that is leading to it? We know that social isolation and loneliness decreases well-being, and this is clearly happening. it's an area that we definitely need to continue to monitor. Persons with dementia have different issues. I mentioned mental health concerns before, but dementia warrants its own concern. Fear and anxiety about the masks. They won't wear them. They don't like other people wearing them. The absence of the regular caregivers, nursing homes not admitting new patients, and in nursing homes themselves, patients became more bedridden, lack of visits from relatives, more mental deterioration. The Diabetic Association in particular, last year reported 50% of their persons not coming for their regular checkups and their prescriptions. Digital challenges. The COVID pandemic has highlighted new issues. There's increased reliance on websites. Every message we heard said, make an appointment, use the app. But older people struggle with digital technology. They need assistance. They don't always have it. 40% of them being alone without younger people. And we tell them that they must make appointments. Some have not come without that. We've had to be encouraged to come. They don't have to, although it's preferable. And the result is that there are information gaps. Fortunately, maybe they're not as much on social media, so they don't see as much of that conversation. And lastly, I want to touch on vaccinations. You will, if I take you back to the beginning of the presentation, and we spoke about the decrease in the case fatality and in that wave, you will see that although not adequate, certainly not adequate, we are seeing an uptake in vaccines by older people. They were targeted in March when the vaccine started, and you're seeing it in the younger age groups, the ones that want to go out a little more from the house. And this, Dr. Webster-Carr may want to comment on this because this would have been September when she shared this with me. But you begin to see, I suspect the second doses here will be higher, but we have to continue to push for this vaccine coverage. And we are seeing the fall, we are seeing the fall in the mortality that is paralleling the uptake of vaccines. And in one of the ministry publications in the COVID conversation, it had been estimated that 125 lives had been saved by the vaccines. Therefore, there is reason for us to encourage, to facilitate, which is being done. The vaccines particularly, well, naturally I'm going to say of this age group because this is the age group we're talking about, but clearly for everybody. So as we look at this, what have we learned? What are the lessons? I think we have, as a general statement, many of us, the country, certainly those of us that have been working in public health over the years, have recognized that public health has been put back onto the front burner. The importance of the basics of public health, sanitation, sanitizing, vaccinations. I mean, there's so much discussion around vaccinations, and yet as a public health practitioner, vaccinations have been part of my life from I started doing public health. So it's really to be a revisit of the basics that we have and an appreciation for those public health workers, our nurses, those who are out doing the community surveys. But there's also some lessons for the senior citizen community, for the policymakers. Last year, the Decade of Healthy Aging was launched. And I think the message very clearly is to strengthen prevention in an aging world. It's flu season. How many have now taken their flu vaccines? These are questions we need to talk about. And I think that the message for those of us, National Council, CCRP, all of us as a country, certainly for policy, is to engage and inspire our policymakers to recognize the importance of this vulnerable group. Now 350,000 Jamaicans are in the age group. The COVID epidemic has certainly highlighted issues around long-term care, support at home. We certainly need more geriatric home care programs. Recently, I have come out very strongly in support of practical nurses, community health aides, those who can go into the home to health. But I think we need to formalize it. I think we need more education, more training, more vetting. But it's also a time to inspire the healthcare workers and individuals to invest and take action to promote healthy aging. Not just of those that are 60 or over, but all of you that are below, hopefully are going to get there one day. And it's a chance for us to strengthen health promotion and to highlight what gets us to being healthy in the later years. Thank you.
Thanks so much, Professor Eldemar Shearer, for breaking down the information so well in your usual excellent style of informing us as well as doing your advocacy. So we are open to question now from the group. Any questions online? We do have one question from a member of the audience. We'll get a mic to her.
All right. Thank you so much, Professor Shearer, for your presentation. A quick question, looking at the elderlies in our society and the way forward, in addition to healthy aging. I'm wondering if within this context we can seek how best to assist those who do not really have family members available to them, because some of the family members are overseas and they live alone. So how best can we assist those group of aging members of our population? And also the technology that they are not able to access, does that not make them more vulnerable to being abused or taken advantage of? Because everything is going online, the banking and all of the other stuff. So how do we help the aging population, especially the group that you have presented on? How best can we help them as it relates to policy so that they will be more comfortable while they are in their present situation, that they can get help and they'll be able to continue to live their normal lives? Thank you.
Thank you very much for that question. And you are very right. Clearly, no one ministry or no one partner can do it. But I think we need to look at strengthening the community-based services, involving the NGOs, involving the private sector. But I think particularly we can revisit the primary care model that we all believe in. There are already chronic disease clinics. I think we need to look at geriatric clinics so that we can do the assessments. Clearly, we cannot meet the needs of 350,000. So although we'd like to, that's the ideal world. But if we had targeted interventions, those are living alone, those that are widowed, those that are not coping, and we could do some mini-mentals, community health aides, community visitors, whether from church or government or the National Council, can be trained to do these visits. Better communication between hospitals and the primary care, so that when somebody's admitted to hospital, the primary care system is notified. There are some very good programs around that I think it is time for us to discuss. This would involve family medicine practitioners, private practitioners, the National Council. And so we need to be more, and even our private doctors can make phone calls to their people if they haven't, their patients, their clients, if they have not seen them for a couple of months, if they've missed an appointment. The model worked well in family planning in the early years. I think it's a model we can adapt now with older people. The abuse is something we need to be cognizant of. I don't know that I have an answer to your question at this time. The National Council for Senior Citizens has been looking into this, setting up a hotline, and looking at ways that we can support and encourage communities and families to report instances where there are problems. Banking is one, and they really cannot deal with online banking. So it's about building the trust between the generations so that the older person does not see it as taking away their independence and their dignity, but recognizing that it's helpful. So I think there's a lot that we can do even within the current limited resources. Our people are our greatest resource, and there is still at the family level, the community level, a basic understanding and care of older people, particularly some of the church groups, the NGOs. I think it needs a partnership.
Thank you, Professor Eldemar Shearer and Dr. Alonge for that question. There are questions on the platform. Please go ahead.
Okay, there are two questions, and the first one is as follows. In the initial stage of the COVID-19 pandemic in Jamaica, the death among the age groups 60 to 69 years was shown the highest. Did the data explore the possible reason for this?
I thought I had covered that. The reason for it is older people's immune system, by virtue of aging, is not as effective in combating the disease. In addition, many older people, in fact, I could actually say most, the one study we did was 82%. The national survey that we did said 74% of older people have a comorbidity. They have another disease, hypertension, diabetes, obesity, and yes, I'm referring to it as a disease, all of which weaken the blood vessels, weaken the systems of the body, and therefore, if affected by COVID, have a stronger response, to put it in non-medical language, and therefore make the person ill. So that's why we're seeing it. And that's why the vaccinations, which reduce the illness in people, is having a positive effect, because then the disease is milder if they do get in contact.
Okay, thanks. The second question is, did you see a reduction in the number of elderly doing outdoor activities, and did it affect their mental status?
Yes, we did see a number of doing it in reduction in outdoor activities. And many older people don't actually live where they can come outside and walk around. Plus, we cannot ignore the role of crime. Many were actually afraid to come out. And interestingly enough, what people told us about is there are too many dogs and they can't run from the dogs, so they have to come out with a stick. We've seen loss of muscle mass. I've seen a few. We don't have figures, we don't have studies, it's anecdotal, on a number of older people that were able to walk, that were able to do activities, become bed-bound, some wheelchair-bound. Some, of course, have not driven for 18 months and will not drive again. Their reflexes are going to be down. So we definitely saw an impact. I think, but this is totally anecdotal, and recognize that my practice is biased because people are coming to me for assessments. So I'm seeing people who are having problems. So I'm not necessarily able to comment against the general population, but definitely seeing more people with memory problems. But that's anecdotal, I don't have statistics.
Okay, thank you.
Okay, thanks so much to everybody. Thanks for your question. Thank you so much, Professor Eldemar Shearer, for sharing in our National Health Research Conference. And we'll move on now and say we close this session, and we'll be back in 5 minutes for the next session. Thank you.
Thank you too.
Hello? 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 Yeah, you. Hold on, and a pandemic winner. You're not wearing a mask, you're not washing your hand, and you're not keep the required 6 feet distancing from other people. And what could I really cause you? You need to stop it. That no mask, no wash, and no distance something there, nah keep. You know what keep? COVID-19. Yeah. It not gone nowhere. COVID-19, they are same way. So here what you are going to do for all of we. Wear your mask, wash or sanitize your hands pan a regular, and yeah, keep your distance, please. And thanks.
Hello, Jamaica. I'm Dion Jacksmiller. It's unbelievable to me whenever I buck up somebody who is still asking if COVID-19 is real. Because my doctor died of COVID-19. I had COVID recently and it was a severe case. Most of my lungs were affected. I am so grateful to be alive. Take COVID seriously, guys. Some people won't be affected, that's true, but others may have long-term effects and some people will die. Let's do all we can to protect ourselves and to protect others.
A message endorsed by the Ministry of Health and Wellness.
Severe pains, shortness of breath, worsening with fever, lack of appetite, extreme weakness, and overall grazing beside death's door. This was my experience with COVID-19. Hi, I'm John, and I'm so thankful that I survived COVID-19. As an asthmatic person who lives alone, I know that COVID could have claimed my life. Listen, don't drop your guard with COVID-19. It only takes a second for you to catch a virus. Initially, I thought I had the flu until things got worse. Don't leave your mask, wash your hands as often as you can, and always keep a physical distance from others. And I want to tell every Jamaican to choose a vaccine before COVID chooses you.
A message endorsed by the Ministry of Health and Wellness. Healthcare workers are working very hard to ensure lives are saved and people recover quickly from COVID-19. But their work is becoming harder because you're not wearing your mask, washing your hands with soap and water, or using hand sanitizer, and you are not maintaining physical distance. Let's limit the need for hospital beds and ventilators. Do the right thing. Cover your nose and mouth with a mask. Practice good hand hygiene and maintain a physical distance of 6 feet between you and others. COVID-19 is not over. Protect yourself while protecting others. A message from the Ministry of Health and Wellness.
Become the hero on the scene by taking the COVID vaccine. Become the hero on the scene by taking the COVID vaccine. Get vaccinated as soon as you get all the facts. Don't listen to the rumors. This vaccine might just make it possible for teachers to sit face to face with schoolers. This vaccine make it safer for everybody, from the young to the young.
So we are now at the Good Samaritan Inn, which is one of our primary locations today for the first vaccines to be administered to frontline workers and vulnerable groups. So far it's been a good day. We started at 8 o'clock, it's now 10 minutes after 10, and a number of persons have gotten their vaccine, including public health nurses, President of the Nurse Association, former Prime Ministers Golding and Pattison, and many others. It has gone smoothly so far.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
I'm encouraging all Jamaicans, healthcare workers, frontline workers, elderly, all persons with comorbidities who are going to be offered the vaccine. I know that there is apprehension out there. I know that persons are afraid. Some persons will tell you don't go. They say I'm not going to go. But I am encouraging you, not just as a healthcare worker, but as a regular Jamaican, protect yourself from COVID-19 infection.
Get vaccinated as soon as you get all the facts. Don't listen to the rumors.
If you are 60 or older, like me, and have underlying health conditions such as high blood pressure and diabetes, you are at a greater risk for severe illness or death from COVID-19.
After more than a year of being under COVID restrictions, it is also time to do what is necessary to get back to life. That's why senior citizens have been prioritized for vaccination.
The vaccine is safe and effective. I have taken it and I'm feeling just fine.
I've also taken the vaccine and I feel so much more at ease.
Get vaccinated and get back to life.
This is an important message from the Ministry of Health and Wellness.
Vaccine 60. Let's go. All approved COVID-19 vaccines are effective against COVID-19 and all known COVID-19 variants. The Johnson & Johnson vaccine requires 1 dose. The Moderna, Pfizer, and AstraZeneca vaccines require 2 doses. You are considered fully vaccinated 14 days after receiving the required number of doses. Don't mix and match 2-dose vaccines. Get the same vaccine for both doses. Vaccines help to prevent hospitalization and death associated with COVID-19. Common vaccine side effects are usually mild and usually resolve in a few days. After getting vaccinated, it's still important to wear a mask, wash hands or sanitize regularly, and maintain physical distance. The quicker we all get vaccinated, the sooner we can all get back to life. Let's strike gold like our Olympians, Jamaica.
Good afternoon. Welcome back, everybody. We are going to start our second scientific session for the conference, COVID-19 and Children and Adolescents. I now hand over to Dr. Abigail Harrison, Consultant Pediatrician and Adolescent Medicine Specialist, University Hospital of the West Indies. Over to you, Dr. Harrison.
Thank you, Dr. Webster-Carr. It's my absolute pleasure to be here with you all this afternoon. And I think I have the real pleasure of working this afternoon with the young persons that I know, all 3 of them. And they are all from the Caribbean Health Research Unit at the UWI. And I think these young persons are just blazing a research trail, and you will all be treated this afternoon. So first up, and I would just pause to just remind everybody that questions and answers can be put in the chat, and we will take all of those at the end of the entire session after these 3 fabulous presenters are complete. So first up, we have Mrs. Ashley Bingham, who is an academic with a passion for research. She worked in the Department of Child and Adolescent Health at the University of the West Indies Mona campus for 3.5 years as a research assistant, and you would have heard Dr. Melbourne Chambers thanking her previously. And this is where her love for research really blossomed. Her research interests centers around, but is not limited to, NCDs in children and adolescents. And she is now going on to pursue her master's, her MSc in epidemiology at the UWI. She's going to be speaking to us this afternoon on the role of socioeconomic status on self-reported school-based physical activity levels among Jamaican adolescents. Over to you, Ashley.
Thank you very much, Dr. Harrison. So my presentation will focus on the role of socioeconomic status on self-reported school-based physical activity levels among Jamaican adolescents. I would like to thank the following investigators, Mrs. Natalie Guthrie-Dixon, Dr. Joanna Simit, and Professor Marshall Tollereed, all from the Caribbean Institute of Health Research, for their input in this study. Globally, the World Health Organization recommends that adolescents achieve a minimum of 60 minutes of moderate to vigorous physical activity daily. However, globally, 81% of our adolescents are physically inactive. In Jamaica, data from the Global Health School Survey in 2017 showed that only 23.2% of our adolescents were achieving 60 minutes of physical activity daily. So school-based physical activity is any activity that is done within the school environment. There are different areas in which this activity within the school environment may be captured. We have structured physical activity, which captures activities engaged in during physical education classes. We have unstructured physical activities, which captures activities engaged in during school breaks. And we have extracurricular physical activity, which captures activity done at school as a part of a sports club or team. So SES is a known determinant of health, and studies have shown that an association exists between household SES and physical activity levels among adolescents. One study conducted in 2016 among South African adolescents showed that adolescents from high SES households spend more time in moderate to vigorous physical activity. Another study conducted in 2010 among European adolescents showed that adolescents from low SES households spend less time in moderate and vigorous physical activity. Thus, the aim of this study was to investigate the association between SES and self-reported school-based physical activity levels among Jamaican adolescents aged 12 to 17 years. And our objectives were: 1, to describe school-based physical activity patterns among Jamaican adolescents attending high schools located in low and high income communities. And secondly, to investigate the relationship between school-based physical activity levels and household SES among Jamaican adolescents. This study was a multi-site cross-sectional study conducted as a part of the Global Diet and Research Activity Group, with Jamaica being one of the participating sites. The study recruited adolescents aged 12 to 17 years, attending 5 high schools located in Kingston, Jamaica. 2 of the schools were from high-income communities and 3 from low-income communities. The schools were purposefully selected based on the SES setting of the environment in which the school was located, while 1 class from each school was randomly selected and the students invited to participate. Students were asked to obtain parental consent, and they were asked to give assent to be a part of this study. So data collection was done using a self-reported questionnaire. This questionnaire collected physical activity data. Students were asked to report on the activity that they participated in, the intensity at which they did this activity, whether light, moderate, or vigorous, and the frequency at which this activity was done. Time spent in moderate and vigorous physical activity were summed to obtain the total amount of time students spent in moderate to vigorous physical activity in each of the following school-based physical activity categories. Using the World Health Organization guidelines, the school-based physical activity categories were dichotomized into most active, moderate to vigorous physical activity group, which included the students who were meeting the guidelines, and those in the less active, moderate to vigorous physical activity group, which included the students not meeting the MVPA guidelines. Socioeconomic status was measured using the students' possession, crowding, and sanitation. These variables were used as indicators for SES. A factor analysis was done, and the scores were used to determine if students were from a low SES household or a high SES household. We then went on to do a mixed effects logistic regression to determine if SES was a predictor of being in the most active, moderate to vigorous physical activity group. Our outcome variables were the school-based physical activity categories, our main explanatory variable, household SES, clustering variables were school and grade, and our confounders were age and sex. Now to our results. Now table 1 shows the distribution of the characteristics for the study sample within the categories of household SES. And we see where majority of the study population were females, and this was seen across both SES, household SES categories. Likewise, most of our students were in upper school grades, grades 10 and 11. 60% of those students were from a low SES household, and 59.1% from a high SES household. Majority of our students were of the Black race, and most of our students from both SES household categories fell within the normal weight BMI. Finally, most of our students attended schools located in a low SES environment. Now, Table 2 shows the percentage distribution of school-based physical activity engagement for the study sample within the categories of household socioeconomic status. So for structured physical activity, overall, only 46% of our students indicated that they engaged in any form of structured physical activity. And when this was looked at in terms of their SES category, we saw where similarly less than 50% of students from both low and high SES households indicated that they engaged in structured physical activity. 60% of our students reported that they engage in unstructured physical activity. And when we looked at this in terms of our SES households, 64% and 57.8% of our students from low and high SES households respectively reported that they engage in unstructured physical activity. And finally, for extracurricular activity, 62% of the study population indicated that they engage in some form of extracurricular physical activity. And looking at this in terms of their SES category, roughly 61% of students from both SES households reported that they engage in extracurricular physical activity. Now, Table 3, sorry, I'm not seeing my screen. Just a minute. So Table 3 presents the percentage distribution of the proportion of students who engage in moderate to vigorous physical activity based on the SES categories. So we see where 28% of students indicated that who indicated that they engage in physical activity fell in the most active, moderate to vigorous structured physical activity group. When this was looked at in terms of SES category, it was still low, with 33% of our students from low SES households compared to 25% of students from high SES household falling into the most active, structured, moderate to vigorous physical activity group. For unstructured physical activity, 17% of our students fell in the most active, moderate to vigorous structured physical activity group. And when we looked at it in terms of household SES, 17% and 16% respectively represented the students who engage in most active, moderate to vigorous physical activity from our low and high household SES. 34% of our students reported that they engage in the most active moderate to vigorous extracurricular physical activity group. And looking at this in terms of our SES categories, we saw where 28% of our students were from low SES household and 36% from high SES household indicated that they engage in the most active moderate to vigorous physical activity group. We then went on to look at the sex distribution, and we saw where sex was significantly associated with physical activity. Within the sex categories, males were more likely, there was a higher proportion of males who fell into the most active, moderate to vigorous structured physical activity group within each of the physical activity categories. So for structured physical activity, 45% of our males compared to 21% of our females were in the most active group. For unstructured physical activity, 36% of our males compared to 9% of our females were in the most active unstructured physical activity category. And for extracurricular physical activity, 45% of our males compared to 29% of our females were in the most active moderate to vigorous physical activity category. Now, Table 5 shows the best fit logistic regression for physical activity engagement in the most active, moderate to vigorous physical activity, structured physical activity category. So our main explanatory variable, SES, was a significant predictor of the odds of being in the most active, moderate to vigorous structured physical activity domain, or category, sorry. Age and sex were also significant predictors of the odds of being in the most active, moderate to vigorous structured physical activity category. So table 6 now shows the, sorry, my screen is, sorry. All right, so table 6 shows the best fits logistic regression for the unstructured physical activity category, looking at how likely students were to fall in the most active, moderate to vigorous, unstructured physical activity group. So SES was not a significant predictor in this physical activity category. However, sex was a significant predictor where our males were more likely to be a part of the most active, moderate to vigorous physical activity group in the unstructured physical activity category. And finally, this table shows the best fit logistic regression for the extracurricular physical activity category, looking at how likely students were to fall in the most active, moderate to vigorous physical activity category. Again, household SES was not a significant predictor of being in the most active, moderate to vigorous extracurricular physical activity, but we did find that school setting was a significant predictor of being in the most active, moderate to vigorous extracurricular physical activity category, where students from attending schools located in high SES communities were less likely to fall into the most active, moderate to vigorous extracurricular physical activity category. Some limitations of this study: the study was self-reported, and thus we know that this can result in students over-reporting or under-reporting their physical activity engagement. The schools were selected using a non-probability sampling methodology, and this may introduce some bias into the sample and may limit also the generalizability of the findings of this study. Also, not all domains of physical activity engagement was accounted for. And our main conclusions are, overall, only moderate levels of physical activity engagement was reported by our students. So when you looked at all of the school-based physical activity categories, we saw where the percentage ranged from 46 to 62%. And when we went on to look at those who engage in moderate to vigorous physical activity, that was even lower, with only 17 to 34% of our students reporting that they engage in moderate to vigorous physical activity. Household SES was found to be a significant predictor of structured physical activity, and this was the only domain in which there was a significant association. And we saw that students from high SES households are less likely to engage in the most active, moderate to vigorous structured physical activity. Our recommendations: the school environment is an ideal environment for physical activity engagement, and we recommend that all our adolescents be targeted for physical activity intervention, given that engagement in moderate to vigorous physical activity is low. And for future studies, we recommend that both objective and subjective methodologies be used to assess physical activity levels, and that all domains of physical activity be captured. These are our references. Thank you for listening.
Thank you very much, Mrs. Bingham. As I expected, excellent presentation. So just a reminder to everyone to hold their questions, and please feel free from now, if you wish, to put them in the Q&A slot so that we can address them when we get to that point. Okay, so we're moving on now very smoothly to our 6th oral presentation for the day. And again, we have someone from the Caribbean Institute for Health Research, and this time from the Epidemiology Research Unit, where Mr. Alfonso Blake is currently an assistant lecturer there. He, however, is also a trained social worker, and having spent 8 years at the University Hospital of the West Indies with a responsibility for patients living with sickle cell disease. He has served as academic supervisor and mentor to UWI final year social work students, and with his similar passion for research, he's on now doing his PhD in epidemiology at the UWI. So Mr. Blake is going to be presenting to us this afternoon on social support and ideal cardiovascular health in urban Jamaica, a cross-sectional study. Over to you, Alfonso.
Thank you very much, Dr. Harrison, and good day, everyone. And thank you for the opportunity to present at the 2021 National Health Research Conference. I am Alfonso Blake, and the title of my presentation is Social Support and Ideal Cardiovascular Health in Urban Jamaica, a cross-sectional study. Social support refers to the functions or provisions given by one's social relationships, such as emotional concern, instrumental assistance, or information. It is built on the perception or realization of being accepted, cared for, or provided with assistance from so-called special individuals. These individuals may be family members, friends, or peers, and the support envisioned can be positive or negative. People with higher levels of social support tend to be in better health conditions than people with lower social support amidst the management of stressful conditions. This is influenced by the social support network they have, which acts as a buffer during stressful events. Information from the WHO NCD Fact Sheet 2021 highlighted that cardiovascular disease include diseases of the heart and blood vessels, and is the leading cause of morbidity and mortality globally, such that between 1990 and 2019, there was a move from 271 to 523 million cases globally, and deaths increased by 50%. Cardiovascular disease accounts for most NCD deaths, up to 17.9 million people annually. Cardiovascular health refers to the absence of cardiovascular disease risk factors, and these risk factors for CVD were defined by the American Heart Association in 2010 based on 7 risk factors, also known as Life's Simple 7. It stated that people can improve through lifestyle changes, and these changes include physical activity, weight, diet, blood glucose, cholesterol level, and blood pressure. There should be a focus on preserving cardiovascular health rather than reducing disease. In urban Jamaica, ICH prevalence is low, a mere 0.5% having all 7 characteristics, and 23% having up to 5 or more in the 20 and older age group. So studies have shown that a lack of social support is associated with a 2 to 3-fold increase in the relative risk of CVD. Essentially, higher social support is associated with reduced mortality and a better quality of life. Social support is characterized by social network, which is the structure of one's relationship, looking at its quality and quantity. Nonetheless, there is variation in social support networks, and not all are supportive. So Nagayoshi in 2014, in a study looking at incident stroke and social network, found that there was a 40% greater risk of stroke in those who had smaller social networks. So we hypothesize that social support can play a major role in the realization of ideal cardiovascular health. However, few studies have addressed this. As such, our objective is to evaluate the association between social support and ideal cardiovascular health in urban Jamaicans. So for our methods, the study was a cross-sectional study and had 849 participants from the Southeast Regional Health area, which is shown by the shaded red on the map. And we collected demographics and ICH characteristics data over a 1-year period from 2018 to 2019. The instrument used was adopted from the Chicago Community Adult Health Study and assessed network size, instrumental support, informational support, and integration in community socioeconomic status was measured using the of value and community poverty. Data from the National Land Agency and peerage and statin were used for this. Our outcome was ideal cardiovascular health, and this consisted of the 7 components of current non-smoking, body mass index less than 25 kilograms per meter square, at least 150 minutes of moderate physical activity per week, healthy diet, normal blood pressure, normal glucose, and normal cholesterol levels. Our exposure variables consisted of the social support variables and potential confounders such as age, sex, property value, and community poverty were all adjusted for. So the data were analyzed using status 16, and descriptive analysis were summarized as means and proportions of outcomes and exposure variables. Bivariate and multivariate analyses were also used. Principal component analysis was used to create a social support score using network size, instrumental support, and informational support. And all analyses were weighted to account for survey design. So for results, so table 1 shows unweighted summary statistics of participants' characteristics by sex. So there was a total of 841 respondents with a mean age of 47.6 with a standard deviation of 18.4. There were 279 males with a mean age of 46.5 and a standard deviation of 19.2 years. For females, there were 562 with a mean age of 48.2 plus or minus 18 years. Table 2 is looking at the ICH proportion categorized by sex, and we only had 0.02% of the population having all 7 ICH variables, and we had 26.6% having all ICH5 variables. So the lowest value was for healthy diet, which was 19.1, and the highest was non-smoker, which had 81.1%. So we had some box and whisker plots here. We show the median value, for the network size and instrumental support. For network size, females had a median value of 4 and males had a median value of 5. That's demonstrated by the graph on the left. And on the right, you have instrumental support, which speaks to the number of persons who are willing to provide a loan. And females had a median value of 3 and males had a median value of 4. And the last box and whisker plot, looking at social network, persons willing to provide advice. Females had a median value of 4 persons and males had a median value of 5 persons who are willing to provide advice if needed. So table 3 shows the final multivariate model looking at the relationship between ICH5 and social support score. And these were created using principal component analysis, where we combined network size, informational support, and instrumental support. We present sex-specific models as there were evidence of interaction by sex in the relationship between ICH5. And the models were also included age, community property value, and community poverty. Among males, social support score was inversely associated with ICH5 with odds ratio of 0.6, indicating a 33% lower odds of ICH5 for each unit increase in social support score. Among females, social support score was directly associated with ICH5 with odds ratio of 1.29, indicating a 29% higher odds of ICH5 for each unit increase in social support score. Community poverty was directly associated with ICH5 among men, indicating that men in poorer communities were also more likely to have ICH5. There was no significant association between community poverty and ICH5 among women. Association with community property value was non-significant in these analyses. Looking at our discussion and our conclusion, so we can say larger social network size is inversely associated with ICH among males, but directly associated among women. And this may be due to the promotion of unhealthy behaviors among men with larger social networks, while social networks encourage positive health behaviors among women. Poverty and ICH may be influenced by physical activity and BMI. So in concluding, gender-specific approaches may be needed when designing social interventions to improve health. And this research was funded by the Bernard Loan Scholars from Harvard School of Public Health. And this here is the end of my presentation. So thank you all for listening.
Thank you so much, Mr. Blake. Excellent. Again, I tell you, we're just firing this afternoon. I'm excited to be here. Thank you. Okay, remember everybody to put your questions in the Q&A section so that we can address them once we're finished with our next presenter's presentation. So next up for oral presentation number 7, we have Dr. Zachary Ramsey, who is a medical doctor and research fellow at the Sickle Cell Unit at the UWI Mona campus. Dr. Ramsey graduated from the UWI in 2013 with his MBBS and worked at the Bustamante Children's Hospital prior to his arrival at the Sickle Cell Unit in 2017. Since he has been there at the Sickle Cell Unit, he has been working as an investigator within or on sickle cell disease clinical trials and studies, examining neuropathic pain, health expenses, hydroxyurea to prevent stroke in children, and the new drug voxelotor. I think he's a very busy fellow. Dr. Ramsey also recently completed his Master's of Science in Epidemiology with distinction in 2020. Congratulations to you, sir. So it sounds like Dr. Ramsey is going to be our third very sharp, hot presenter for the afternoon. And he will be talking to us this afternoon on high rates of reattendance following outpatient vaso-occlusive crisis treatment in Jamaica, a 3-year retrospective study. Over to you, Zachary.
All right, thanks. Afternoon. Really hope I can live up to those expectations. Right, so I'll be presenting today on high rates of reattendance following pain treatment at the Sickle Cell Unit. Are you seeing my screen? Okay, right. So we know that severe acute bone pain, which is known as a vaso-occlusive crisis, is the most common cause of admissions among sickle cell disease patients. In fact, when they're admitted and then they're discharged from hospital and we follow them up for 30 days, the readmission rate has been found to be as high as 50%, which is of course very high. Now, when we look on all causes of admissions among sickle cell disease patients, the 30-day readmission rate is also high. It's as much as 25%. And in those cases, the vaso-occlusive crisis is still the most common cause. Now, frequent vaso-occlusive crises definitely result in worse productivity, as we can imagine, and significantly worse quality of life. And they also have negative impacts in terms of high healthcare costs and resource utilization. Now, mortality is also high, particularly among patients who readmit within 1 week. It was found to be as high as 11% in that paper. Now, we can also look at reattendance as another outcome. So if we consider that patients are initially treated and followed up over 30 days, they can either be admitted to hospital during that follow-up period, or they can return for outpatient treatment. And reattendance would refer to either of those two outcomes. Now, a study looking at the rates of reattendance in terms of outpatient treatment found that it was as much as 15% within 30 days. So we can see that that's also very important. Now, just to talk about the Sickle Cell Unit, it is an outpatient research clinic at the University of the West Indies, and we offer routine clinical care as well as emergency daycare services. So the daycare, it's an 8-bed facility that has 4 doctors and 3 nurses, and we treat acute sickle cell disease complications such as the vaso-occlusive crisis using opioids, intravenous fluids, supplemental oxygen, antibiotics, and other medication. In another study that was done of the daycare data, we found that 70% of patients who presented with a vaso-occlusive crisis were discharged for home after treatment. However, we really have not investigated until now what happens to these patients after they go home. So that's what the treatment room looks like with all the medication. And then this is what the actual area with the beds where they're housed. Now, in high-income settings, such as in the United States, they have found modifiable factors that contribute to readmission. And it's unfortunate because these outcomes and those factors just have not been assessed in low and middle-income countries, such as Jamaica, where sickle cell disease actually is often a neglected disease. If we were able to predict which patients reattend, then of course we could minimize the burden on the healthcare systems and reduce morbidity and mortality. So keeping that in mind, we set out to do this retrospective study and this is among sickle cell disease patients at the sickle cell unit, coming for treatment of a vaso-occlusive crisis at our daycare. We aim to determine the percentage of patients who reattend within 30 days, and also to determine the clinical and socio-demographic factors that predict this reattendance. So we performed an audit of all the records of patients who were seen there between 2017 and 2019. And we combined results from a search from an electronic database, in addition to records of a physical book in which all the visits to the daycare are recorded. We included patients of all ages, sexes, and genotypes, but only if they were discharged for home by the physician or if they left against medical advice on their own will. We excluded patients if they were referred to hospital for admission. So this is just a flowchart illustrating to you what we did as we went along. The dashed lines indicate what we intend to do in our final study. This study that I'm presenting here is a pilot. So initially we did a literature search to identify some of the candidate predictors that we'd be interested in assessing. Then we went to our physical records and we extracted the data and we prepared the data after that. So this included coding it, handling missing data and cleaning the data in general. If we were to do the full study, we'd also be splitting it into a test data set so that we could test the model afterwards. But in this study, we went on to build the model. And our goal really was to try and build the most parsimonious model possible, meaning the model that is as simple as possible with the least amount of variables that still best predict the outcome of reattendance. So a research medical doctor, that was myself, and 3 trained medical students, we assessed the records for eligibility, and then we collected the data from physical records directly into a REDCap database. We assessed 35 candidate predictor variables. This included age, sex, some clinical and treatment variables, among others that I will get into detail with. Now, these were the outcomes that we're particularly interested in. We, of course, recorded reattendance if they visited any healthcare facility for an acute or acute on chronic illness within 30 days of daycare treatment. We also recorded the diagnosis at the time of reattendance, and we were also looking for if any of them unfortunately died. So in terms of our statistics, we did panel data analysis in Stata 16, and we described our data using means with standard deviations and frequencies with percentages and cross tabulations. And in order to account for the fact that patients could have more than one visit, we performed mixed effects logistic regressions, both univariate and multivariate models. In terms of our missing data, we performed pairwise deletion to handle all the missing data that was present in the data set. Now, we also performed a sensitivity analysis where we excluded subjects who did not have any follow-up documented in our records after that initial daycare visit, because it could just be that we don't know what happened to them afterwards. So we need to compare what happens when they're included and excluded in the analysis. So we had 668 initial visits among 386 patients. There was a mean age of 31 and 53.9% were female. The most common diagnoses at the time of the initial visit, apart from the vaso-occlusive crisis, was the acute chest syndrome, asthma, and leg ulcers. We don't routinely record hematology studies on patients who come in with a simple vaso-occlusive crisis. So we recorded their steady state hematology, which in this case we considered as their last complete blood count. And we can see that the mean hemoglobin was 8.8, white blood cell count 12, and reticulocyte count 10. Most commonly, patients were of a severe genotype, that's either SS homozygous genotype or S beta thalassemia major. And we recorded a number of other variables. Because it is 35, I can't go into as much detail as I'd like with all of them, but we looked at the number of vaso-occlusive crises in the last year, the number of daycare visits in the last year, their compliance with routine care, their hydroxyurea use. We also looked at a numeric pain score, which at the beginning of treatment was on average 8.4 and moved to 3.7 at the end of treatment. We looked at their duration of pain prior to daycare, which most commonly was 1 to 3 days. And we also looked at their vitals. We looked at time variables associated with their treatment. So how long on average they spent in the daycare and how long on average they waited to get medication and get opioid medications. And we also looked at a number of other variables involving their opioid use. I should mention that the numbers under the N column just signify how many, they denote how many records we had for each variable. So it just goes to show you that we did have a fair amount of missing data. So in terms of our outcomes, we had 177 patients reattending, that was 26.5%, 9 discharged against medical advice, and there were no deaths. The most common reattendance diagnoses were actually the vaso-occlusive crisis itself and acute chest syndrome. Now, very few patients actually had multiple reattendances within the 30 days. Now, these are the different reattendance outcomes that occurred within the 30 days. We can see that of those who actually reattended, the most frequently reported one was that they came back to the daycare, that was 9.1%, whereas only 2.1% admitted to hospital within that 30-day period. When we looked at univariate mixed effects logistic regression models, that's looking on each variable, each candidate predictor variable against the outcome in a model alone, we found that severe genotype, having more vaso-occlusive crisis in the last year and more daycare visits in the last year, as well as having current leg ulcers or having a concurrent diagnosis of acute chest syndrome, these increased the odds for reattendance. However, when we looked at these variables together in a multivariate model controlling for other variables, other important variables, we found that only having more daycare visits in the last year, having a leg ulcer or having an acute chest syndrome at the initial visit increased the odds for reattendance. Now, there weren't any significant changes in the multivariate analysis when we performed the sensitivity analysis. The only changes were in the univariate analyses. We found that subjects who had 7 days, who took 7 days to present to the daycare had higher odds of reattendance when compared to those who presented less than 1 day of duration of pain. Now, just to close off with our discussion, in answering objective number 1, we found that 26.5% reattend, but only 2.1% actually admit to hospital within that 30-day period. Now, of course, this is lower when we compare it to other studies done in high-income settings. It definitely suggests that the daycare model that we have here may be successful in managing pain on an outpatient basis. So, it definitely suggests that it appears to prevent admissions and readmissions. In fact, when we looked on the data in 1999, they found that 70% of patients treated at the daycare here were successfully treated in 1 day. Only 20% of them actually ended up returning. And similarly, in the United States, at a facility, they introduced a daycare model and they found that it reduced admissions from the emergency department by 40% over the first year that it was introduced. They also found that daycare patients were 5 times less likely to be admitted when compared to those from the emergency department. Nonetheless, outpatient reattendance is still high, and it's higher than we've seen in other settings. So that is something that we definitely intend to address with our full study when we finally build that model. Now, there are some limitations to the data that we have to consider. Of course, retrospective records, particularly from just one source, that's very unlikely to document all the healthcare visits that the patients may have. And as I mentioned, we did have a fair amount of missing data. These are things that we will address in the full study. In answering objective number 2, we found that a diagnosis of acute chest syndrome or a leg ulcer at the initial visit, as well as having more vaso-occlusive crisis documented in the previous year, were predictive of reattendance. And acute chest syndrome is a common complication of vaso-occlusive crises in many studies, and it definitely can significantly affect morbidity and the outcomes. In fact, in another study, they found that 70% of patients who were in hospital with a diagnosis of acute chest syndrome were initially admitted for a vaso-occlusive crisis. Now, there is a clinical prediction tool that has been published that can predict secondary acute chest syndrome among patients who are admitted initially with a vaso-occlusive crisis. And some of the variables they look at include the retics, pain score, a leukocyte count, and their hemoglobin count. Now, as I mentioned, we do intend to conduct a prospective study that accounts for a lot of these limitations that I spoke about, and also will incorporate several other domains that are known to affect sickle cell disease severity and vaso-occlusive crisis outcomes. And some of these other variables that we have found here, such as leg ulcers, definitely warrant further assessment in that final model. So thank you very much for listening. I just want to thank the other authors on the paper and Dr. Novi Younger-Coleman, who helped with the statistics, as well as the patients, doctors, and nurses at the unit. Thank you.
Thank you, Dr. Ramsey. I think I can comfortably say you lived up to the high expectations set. And I think we all can agree that our young researchers from the Caribbean Institute for Health Research really blazed the trail this afternoon. So I'm going to open up to see if there are any questions from our attendees. I see one here. No, not seeing there. Are there? Well, let me start. I did have a question for Mr. Blake with regard to the 6 differences that were found. If you were able to postulate any causes, I'm just thinking to myself, you know, is it the stigma around healthy or health conversation that men don't have those conversations? What are your thoughts based on the work you did?
Hi, thanks, Dr. Harrison. That's a very valid point, and I do also think that, so I've done some work in stigma in the past, and you know that some males really don't have that health conversation for real. And the smoking part, that was kind of surprising that you have a lot of persons who don't smoke. So that's very good. But the physical activity part, they need to work on that. And then the part on cholesterol level and the BMI, those need some work.
Yeah, we have a lot of work.
You find that men in the, let's say, lower income communities now, they probably do more hands-on work, more physical activity stuff. So you'll find that they would probably have a higher odds of having more ICH characteristics.
Excellent. Thank you. Well, I mean, I think this information will go a long way towards guiding and informing any policy changes in terms of, you know, making it more gender specific, the interventions that we have, which I think we realize we need to do. So that's great. Okay, let me see if there are any other questions. I'm not seeing any. I had one more question. Okay.
Good afternoon to the She's still speaking?
Go ahead. Were there questions?
Okay, thank you, Dr. Harris. Thanks to all three presenters that have presented in this second session. Very good presentations. All right. To Mrs. Bingham, as it relates to unstructured activity, I'm not sure if I missed it. Did you find out more males were involved in more unstructured activity? That's one. And did you find that the young people overall were more, irrespective of socioeconomic group, as it relates to unplanned activity, unstructured activity or structured activity? Can you just remind us what it is that you found? I want to make a point, but I just want to be reminded as to what it is that you found.
Thank you for your question. So yes, for unstructured physical activity, the males were more likely to engage in the most moderate to vigorous physical activity, meeting the World Health Organization guidelines when compared to our females. Could you repeat the second part of your question?
All right, I'll just go on to make the point. As in Jamaica, you know, when I was a young girl, we used to go outside and play cricket and so forth. Did you find that our young people were less involved in just activity overall when you compared your data with that which you might have found in the literature of studies previously done? And is there any plan to look further into this as to what would be causing the inactivity? One, and if it is that you did find that the young people were more likely to be involved in unstructured activity, is there some policy direction that the ministry could consider under its Jamaica Move program, with the provision of more park or areas for kids to have so that they can be involved in more unstructured activity? Over. Thank you.
All right, so the findings were are similar to what is seen in the literature, where yes, there is general engagement in unstructured physical activity, but where we're having an issue is where a lot of our students, though they're engaging in physical activity, they are not doing much moderate to vigorous physical activity. In terms of other factors, we do consider that screen time and the technological age is influencing physical activity levels in our adolescents. And definitely we would recommend that in terms of on a large scale, policies be directed towards our students to get them more involved in physical activity, because we did find that there is a proportion of students who are not engaging, and this policy would help we would really want to target students engaging in moderate to vigorous physical activity, meeting the WHO guidelines, so that we can, as we know, any habits that are formed during the adolescent years, they are usually transferred into adulthood. And so if we have good physical activity levels, habits being developed here, we'll have our adult population, upcoming adult population, being more physically active. And this may influence our current NCD crisis.
Okay, thank you so very much.
As a follow-up, just a quick addition. With the pandemic and the children staying home, what do you think? How are we going to resolve this one? Because you know that it's a technology age. The children are at home doing online classes, and they are already used to their devices. That is their toy, that is their study tool. So how are we as a nation going to help this next generation to come out of that setting. How are we going to do that? It's a question for you. So it's not necessarily what your study is saying. It's something you can just express your opinion. Thank you.
So yes, definitely. With the measures taken for the pandemic, we would expect, because this study was done before the pandemic, and if the levels were that low then, I can only imagine what the levels are now, given that most of our students are inside. You're not in the school environment, which have the equipments and the facilities for them to engage in physical activity. And most of them at home, we know that sedentary behavior is on the rise in our adolescent population. Just generally, we really need to look into interventions to target how we target our adolescents, how we get them involved in physical activity. Just thinking off the top of my head, I'm thinking that we could probably utilize the technology in some way, develop some apps where they're seeing their physical activity levels and linking it to showing them that, look, you're at a space where you're at a risk, you're not getting enough physical activity for the day, and show them that this puts them at a risk for developing non-communicable diseases. And so if they're able to see that on their devices, then it may serve as a way to push them to get out of the house and be more physically active.
Well, thank you very much. I like that one. So I was thinking you could add that we send them off to school. What do you think? I like the big smile. I like the big smile. Thank you.
Okay, are there any final questions before we wrap up this session? Are there any questions from persons at the hub? I'm not.
Hello. Good afternoon. All right, just not really a question per se to the individuals, but just a little clarity from Mr. Alfonso Blake. And I just want to also add that all three presentations were really lovely. And as it relates to the nature of each of them, we see how well they will impact our healthcare delivery system and some of the plans going forward to really impact health. As it relates to cardiovascular disease, Mr. Blake, you mentioned something about preserving cardiovascular disease rather than something. I just want you to clear up that for me, that was somewhere on one of your slides. Is he gone? Health, disease. No, man, preserving cardiovascular something rather than. It was a statement that he was making. I'm not quite sure if I got the clear aspect of that. I don't know if he remembers.
Let me clarify. I'm looking for the committee reference.
That slide that speaks to preserving.
Just a second. Oh, yes, I said there should be a focus on preserving cardiovascular health rather than reducing disease.
Okay.
So instead of just...
Right, right, okay. All right, very good, thanks.
Sure, no problem.
So there are a few questions in the Q&A. First up for Dr. Ramsey. There's a question here. Did you find any socioeconomic factors affecting or possibly contributing to the readmission, such as poor dietary habits? I'm not sure if you would have been able to explore those based on your study, but can you address that question for us?
Right. So no, I wouldn't have been able to address that because it is a retrospective study. So we're just looking in medical records. We're just looking in medical records and looking back. We wouldn't have those kind of things readily available. The study that we're planning to do in the future, well, we've already fully planned it and so on. We will try and look on many different factors that can affect pain, things like environmental factors, we plan to do interviews with patients and find out if things, they may allude to things like diet and sleep and so on. So it's a very expansive study where we'll look on many different factors, but you would need to do that prospectively. You need to do that looking ahead. We wouldn't have all of that information readily available.
So while I have you on the floor, there's another question for you. How do you see these data helping in the initial evaluation of the patient who comes in with vaso-occlusive crisis from the point where you are now, so even before your larger study?
Right. Well, I should start by saying that, as I said, it was a pilot study. So the goal really was to assess feasibility and get an idea of what we can do. Because of some of the limitations, we didn't get, very useful, I shouldn't say useful, but we didn't get signals that are, that stand out a lot. So typically in a clinical prediction model, what you might have, let's say you want to find out which patients with COVID will admit to ICU. And they'll have a number of different variables like age, vaccination status, whether they have hypertension or not, their random glucose on presentation, oxygen saturation, and so on. And then when you're able to plug in all of those values together, it can tell you their probability of going to ICU. So because this was, just a feasibility study, and because of some of the limitations of that retrospective data, in particular the missing data that we had, we didn't get very hard signals, as I would have just described with that COVID scenario. We didn't get very hard signals that we could look and say, okay, if you see this, we can do that. So the purpose really was just to assess feasibility and to give us an idea of some of the limitations that we need to account for. But I didn't get hard signals that I can necessarily use in a clinical setting.
So I guess you'll be looking for those hard signals in the bigger study.
Right.
Okay, and then our final question for this section for Ashley. Do you think there is a need for sex-specific physical activity interventions based on your data?
So yes, definitely there is a need for sex-specific interventions, because we saw where in each of the categories, especially when we looked at moderate to vigorous physical activity, our females, they were just not, the proportions compared to our males were very low. In most of the categories, our males were like, the proportion was like twice, and in even one category about 3 to 4 times higher in terms of the amount of our females compared to males who are engaging in physical activity. So definitely we have to target the females for physical activity intervention, especially moderate to vigorous physical activity intervention.
Okay, thanks so much for answering. So just to close off, to say a special thank you to all 3 of our presenters, Mrs. Bingham, Mr. Blake, and Dr. Ramsey. I think it was an excellent session that we had this afternoon, and I hope you continue to blaze the trail in research. And I will hand over to the host.
So good afternoon again, everyone. And we want to thank the presenters who participated in that last session. So we're just going to give them another round of applause. And we also want to thank the participants who have journeyed with us from the very beginning this morning and have stayed the course. We have had a very rich day of research, and we really celebrate the quality of the research that has been presented. And we have another rich day ahead of us, and I just wanted to highlight some of the presentations for tomorrow. We will begin at 9 a.m. and we will start with scientific session 3, which will be on COVID-19 and chronic non-communicable disease. We also have a scientific session on laboratory testing, and we have a very special panel discussion on men's health, a multidimensional perspective, And our panelist will be Professor William Aiken, consultant urologist and lecturer at the UWI, Dr. Donovan Thomas, president and founder of Choose Life International, and Professor Rachel Irvin, professor of clinical biochemistry and sports science of the UWI. And we will close our session with another panel or session on COVID-19 and chronic non-communicable disease. And so we encourage you to come out again tomorrow. We have much in store for the next 2 days. We also encourage you to complete the evaluation forms. We take them seriously every year in terms of improving the conference and to get new ideas in terms of the presentations. I also want to highlight that on the final day, we will be doing for the first time a breakout room session where we will have the opportunity for networking with different groups such as the Jamaica Statistical Society, the Caribbean Institute for Health Research, the Nurses Honor Society, Michael University College, Violence Prevention Alliance, and the University of Technology. So there is much in store. Thank you. And we look forward to seeing you again tomorrow at 9 a.m. And we will close today by rerunning the award ceremony which took place this morning, which celebrated our researchers from 2020. So thanks again and see you tomorrow.